Our Father in heaven, we praise you for this wonderful day. Thank you for everything we have. We glorify you for all the blessings that you have given us all these years. We are gathered here today for the Philippine Urological Association Mindanao Chapter's 16th Postgraduate Online Course, the Urology Practice Acts 2.0. Bless all the participants of this activity, that they open their minds and receive the learnings from this event. Guide the speakers with your gift of wisdom as they share their time, expertise, and experiences. Bless the organizers and sponsors of this event as they contribute their efforts and resources to make this event fruitful. As we face the struggles and challenges of this pandemic, we pray for health and safety of everyone, our loved ones and family. Protect us from all dangers. We pray that we use the insights and wisdom of this venture in the practice of our professions as health workers in the care of our patients. All this endeavor we do for your greater glory, Lord. Amen.
Bayang magiliw, perlas ng silanganan, alab ng puso, sa dibdib mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisiil. Sa dagat at bundok, sa simoy at sa langit mong bughaw, may dilagang tula at awit sa paglayang minamahal. Ang kislap ng watawat mo'y tagumpay na nagniningning. Ang bituin at araw niya kailan pa may di magdidilim. Lupa ng araw ng walhati pagsinta, buhay ay langit sa piling mo. Aming ligaya na pag may mga api, ang mamatay ng dahil sa'yo. Puso ko'y tinip ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pawiin. Idalangin natin ang tapat sa may kapal, ay lunas sa lahat. Awit ng DNA, tayo ay mag-iwan. Magtulungan, magunlad ng bayan. Ang kailangan, ibigay sa kanan, kalusugan at kasaganaan. Ang puso ko'y tigib ng kasayahan, dahil ako'y nasama sa tanan. Ang lahat may gintong nasa, makisig at masigla. Kapisanan ay tunay ang damdamin, suliranin itong baya'y pamilin. bagamat may lunas sa lahat. Ilalangin natin ang tapat sa may tapat, may lunas sa lahat.
Good morning, ladies and gentlemen. The day of the annual PUA Mindanao chapter postgraduate course has come. In behalf of the chapter and in my capacity as the president of the PUA Mindanao chapter, I would like to convey my heartfelt welcome to all the participants and give my appreciation for joining us in our 16th postgraduate course, the second online. I welcome all the great speakers who accepted our invitation and share their knowledge and experience with us. This is our second postgrad in digital platform in line with the social distancing norms due to COVID-19 pandemic. Will this be the last? We all don't know. What is only sure, this will be the last postgrad during my second year term as the president of the chapter.
Mindanao is the second biggest island in the country, next only to Luzon, spanning a vast area of 97,530 square kilometers. Around 25% of the population lives here. 44 urologists at the moment practice here, mostly in the following big cities of Davao, Cagayan de Oro, General Santos, Zamboanga, Iligan, Butuan, and Cotabato. They are united as a team by the pioneer chapter of the PUA, the PUA Mindanao chapter. The success of the chapter is in general, and this postgraduate course in particular, depends on each member. Your active involvement and contribution to the chapter will be of vital importance in determining our essence and impact of our existence in Mindanao. I would like to convey my appreciation to Dr. Nimrod Firaza for heading this postgraduate course for the second consecutive year. I see you to be in the PUA Executive Council in the next few years. Same appreciation is extended to the ECE Pharmaceutical for being our exclusive postgrad course partner, also for the second consecutive year. The 44 Mindanaoan urologists will not forget this. To all who registered for this postgrad, have fun and thank you for joining us. Not making this longer, as the president of the PUA Mindanao chapter, I declare this 16th postgraduate course for the year 2021 finally open.
Good morning, everyone, and let me welcome you to the 16th postgraduate course and second online postgraduate course of the PUA Mindanao chapter. I would like to congratulate Dr. Rod S. Hipol III, President of the PUA Mindanao chapter, Dr. Paul Nimrod Firaza, the overall course director, and all the other members of the organizing committee for coming up with this exciting postgraduate course despite the limitations brought about by the medical crisis. To all attendees and participants, as well as all the lecturers of this event, let me greet you a wonderful and blessed good morning. The PUA recognizes the efforts of PUA Mindanao chapter for actively pursuing educational activities like this, and likewise acknowledges the fact that they belong to one of our most active chapters. It never fails to deliver quality conventions and had always involved other specialties and other medical fields in its target beneficiaries. The theme for this educational activity is unique: Urology Practice Hacks 2.0. So what does hacking urology practice means? I was made to understand that it means learning bits and pieces of urology and applying the tips and tricks for management of patients with common urological problems. In other words, this activity aims to provide a learning module for a quick and clever solution to a problem that can be used by both urologists and interested healthcare professionals and frontliners that will aid in the immediate management or solutions to some urologic cases. I commend the PUA Mindanao chapter for their advocacy and unselfish act. Please let us not think that we are giving away the practice of urology to others, but rather we aim to collaborate and partner with other specialties and frontliners to be force multipliers that would benefit no other but the greatest number of Filipino patients who needs utmost care. We need to realize that there may not be enough urologists in this country to immediately attend and offer a helping hand to all patients, especially in the far-flung areas. Thus, the need for force multipliers whom we would be working closely hand in hand. The credentialed urologist would then be left to deal with the more directly difficult, or if I may say, challenging and complex urologic cases, of course, including surgeries. So, as not to delay the excitement further, I would like to congratulate and recognize the efforts of the entire PUA Mindanao membership for a job well done. Again, welcome everyone, and together we join in participating and learning in this worthwhile activity. Thank you very much.
Our next speaker is a physician scientist with over 10 years of international experience in clinical research and development, regulatory and medical affairs, and program management of vaccine discovery and development in Asia Pacific, Europe, Latin America, and Africa. He's a global medical director for Takeda's vaccine business unit, a TED educator, and a digital health expert at the World Health Organization. He has developed TED lessons on influenza, tuberculosis, meningitis, and coronavirus, which have been translated into 24 different languages and viewed by millions globally. As the first Gates Global Health Fellow from Asia at the Bill and Melinda Gates Foundation, he launched the Collaboration for Tuberculosis Vaccine Discovery, an international network of over 70 institutions from all over the world dedicated to fostering collaboration in TB vaccine discovery. Dr. Sanikas is a part of the Safety Platform for Emergency Vaccines project that creates resources and tools to facilitate COVID-19 vaccine safety, clinical trials, and pharmacovigilance. Dr. Sanikas earned his bachelor's degree, cum laude, and MD from the University of the Philippines, Manila. He has postgraduate degrees in vaccinology and clinical development, cum laude, Università di Siena, Italy. Infectious diseases, London School of Hygiene and Tropical Medicine, UK. Health Economics, University of Aberdeen, UK. Clinical Risk Management, University of Leeds, UK. And Public Leadership, Harvard Kennedy School, US. Dr. Sanikas is a Fellow of the Royal Society of Tropical Medicine and Hygiene, and a Fellow of the Royal Society for Public Health, and a Fellow for the Royal Society of Arts. Let us now welcome our next speaker and my friend, Dr. Melvin Sanikas.
Good morning, good afternoon, everyone. First of all, thank you to the organizers for inviting me to be part of the EuroHacks 2.0 postgraduate course. Just over a year ago, before the pandemic started, vaccines were not really considered something worthwhile to talk about, and people were, for the most part, vaguely familiar with vaccines. But since the end of 2020, COVID vaccines have been in the spotlight and have become an everyday topic of conversation. And almost everyone now has some idea of the principles of vaccination, and that's good. But it also has made vaccines the topic of lots of misinformation and disinformation. And it's always a challenge to talk about a topic as popular as vaccines are at the moment. But I will try my best to squeeze the important bits in the next 30 or 40 minutes. First of all, some disclosures. I am employed by Takeda in the vaccines business unit, and I work as a technical consultant or an advisor for some of the groups and companies listed here, but I'm not representing any of them today, and I am here in my personal capacity as a physician and a scientist who has been working in the field of vaccines and vaccinology for over a decade now. So 1 year and 4 months since the pandemic was declared, we are now here. And I honestly thought that because we already had vaccines in December last year, we would be in a much better situation by now. But the vaccines have been distributed mostly in the rich countries. And although there are signs that the cases are decreasing, I don't want to be too excited because the cases have decreased 3 other times in the past. Yet we are here again in a situation where it seems like the outbreak is not yet ending anytime soon. But the other thing that we should be hopeful about is the fact that unlike this time last year, we now have drugs that have proven to be effective in reducing mortality or reducing hospitalization or reducing death or hospitalization from COVID. My talk today will have three parts. First, the different vaccine types or technologies, COVID vaccines that have been approved by at least one National Regulatory Authority or NRA, and SARS-CoV-2 variants. And I hope that these three topics, with these three topics, I will be able to cover as many subtopics in my talk, and hopefully you will have more specific questions after. So firstly, the different vaccine types or technologies. The two main traditional approaches are, as we know, the inactivated vaccines and the live attenuated vaccines. So when we talk about inactivated vaccines, these include most influenza vaccines and the inactivated polio vaccine. They contain a version of the organism that has been killed or inactivated using chemicals, heat, or radiation. And the killed form acts as an antigen and stimulates the body to create an antibody response. Inactivated vaccines can be given to people with compromised immune system. It is a well-established technology with defined pathways for regulatory approval. However, it requires special laboratory facilities to grow the virus safely before it can be inactivated or killed. Then we have the live attenuated vaccines. So this include measles, mumps, rubella vaccines. They contain attenuated or a weakened form of the disease-causing pathogen. They can still replicate, but they are not able to cause disease. The attenuated organism acts as an antigen and stimulates the body to create a robust antibody response, but it may risk causing disease in people who have weak or compromised immune systems. There are no approved live attenuated vaccines for COVID, but there are candidate vaccines being developed. It is a well-established technology as well, with defined pathways for regulatory approval. But like the inactivated vaccine, for live attenuated vaccines, you require special laboratory facilities to grow the virus first before you can weaken or attenuate them. Then we have the protein subunit vaccines. They do not contain the organism itself, but use fragments of protein from the pathogen as antigens to trigger an immune response, and doing so minimizes the risk of side effects. But also this means a weaker immune response as compared to vaccines using the whole pathogen. Because of this, subunit vaccines require adjuvants or substances to improve the immune response. An example of an existing subunit vaccine is the hepatitis B vaccine. And there are over 60 protein subunit vaccines against SARS-CoV-2 under development, including the RBD trimer of S protein, S1, recombinant S proteins, M proteins, and so on and so forth. This type of vaccine technology is also well established. It's relatively stable. It's relatively complex to manufacture, and you almost always need adjuvants and boosters to make sure that the immune response is durable. And it takes a while to really determine the best antigen to use for this type of vaccine. Then we have the viral vector vaccines. These vaccines use either a harmless virus or plasmids, and these harmless viruses are used to give genetic instructions to produce antigens. Genes of a pathogen are inserted into the genome of the vector, which infects host cells and then travels to the nucleus to express the genes of the pathogen. Viral vector vaccines can mimic natural infection and trigger a strong immune response. And vectored vaccines can be replicating, where viral vector is produced and are able to infect new cells, or non-replicating, where the vaccine antigen is produced, but the viral vector cannot be reproduced. And this is also a well-established technology. We have existing viral vector vaccines that have been approved in the market. The immune response is robust, and it involves B cells and T cells. However, previous exposure to the vector could reduce effectiveness, and it's also relatively complex to manufacture. Then last but not the least, we have the DNA or the RNA or nucleic acid vaccines that use genetic materials, either an RNA or a DNA, to provide cells with instructions to make the antigen. In the case of the mRNA vaccine, it contains the messenger RNA, a single-stranded RNA molecule that complements DNA and is created when the DNA is transcribed by RNA polymerases to create mRNA. Once the genetic material enters the human cells, it uses our cells as machinery to make the antigen that will trigger an immune response. Because the antigen is produced inside our cells and in large amounts, the immune response is expected to be strong, as we've seen in the mRNA vaccines available at the moment. The existing RNA vaccines need to be kept at ultra cold temperature, which may prove to be challenging for countries in low and middle income countries. It's a relatively easy to manufacture these kinds of vaccines, and booster shots may be required. So now we move to the COVID-19 vaccines that have been approved by at least one national regulatory authority. So this is just showing us that in June last year, there were 130 vaccine candidates and 17 of them were in clinical trials. And at the moment, there are over 100 vaccine candidates in the different stages of clinical development, phase 1, phase 2, phase 3. And I will be discussing here some of the vaccines that have been given approval by at least one national regulatory authority. So we start with the first vaccine to be approved, which is the Comirnaty or the Tozinamiran or BNT162b2, which is the mRNA vaccine developed by Pfizer, BioNTech, and Fosun Pharma. The efficacy is 95% against symptomatic disease, and it's given 2 doses 3 weeks apart intramuscularly. As we all know, this is the vaccine that needs ultra cold chain. However, studies have been done, especially in Europe and Israel, and now they are able to say that the vaccine can be stable at room temperature for at least 30 days. And because this is the vaccine that has been used in many developed countries, we have lots of data. And we have seen data comparing this to data using this in countries that have many of the variants, and the vaccine has proven to be still effective in places where the variants were circulating. And one good thing about this vaccine is that it is being used in some countries in the UK and in Spain in a sort of a mix and match type of study, where the first dose could be either Pfizer or AstraZeneca, and the second dose could be either Pfizer or AstraZeneca. And it seems like this is going well, and preliminary studies in Spain have shown that it is okay to mix and match these two vaccines. And we are waiting for the results from the Oxford COMCOV study. And then we have the Moderna vaccine, which is also an mRNA vaccine. The efficacy is vaccine efficacy against symptomatic disease is 94.1%, and it's given in 2 doses, 4 weeks apart, also intramuscularly. Also needs ultra cold chain, but not as cold as Pfizer. And the developers are also trying to optimize the vaccine so that, like the Pfizer vaccine, it can be used in normal temperature in at least for at least 30 days. And this is also a vaccine that's been used in many of the developed countries. So we are seeing a lot of studies, data from the studies showing that the vaccine is effective up to now. So it has been used in many countries for at least 8 months now, and it is still effective. So that is a good sign. In March, they started testing in babies and young children, and they also started a trial to see whether a new formulation specifically for the B1351 variant will be as effective as the original formulation. Then we have the AstraZeneca vaccine. It's called Vaxzevria, or the AZD1222, or Covishield in India. The efficacy is around 62 to 90%, depending on the dose. But the study done in US showed that the efficacy is actually around 80%, 79, 80%, and that is good. It's a 2-dose regimen given 4 weeks apart. Studies have shown that if you increase the interval from 4 to 7 weeks to 8 to 12 weeks, so in other words, if you give if you increase the interval, vaccine efficacy is better. It is stable in refrigerators for at least 6 months, and this is the vaccine that's been used the most globally, because this is the vaccine that's being distributed in the COVAX facility of WHO. So in South Africa, there was a small trial that failed to demonstrate protection against the variant there. So the South African authorities stopped using this vaccine for a while. And AstraZeneca and Oxford announced a few months back that they will start trials in children as young as 6 years old, and they are also working on a new version of the vaccine tailored to this B1351 variant. As you know, this is the vaccine that's been implicated in several news articles and news coverage in the media a few months back because of the association with blood clots, and we now know that the incidence of cerebral venous thrombosis, or CVT, in AstraZeneca vaccine is around 5 in 1 million doses given. And in mRNA vaccines, it's 4 in 1 million doses. And we know that the incidence of CVT in COVID infection is much higher, which is 39 in 1 million. Then we have the Sputnik V vaccine, also known as GAM-COVID-Vac. The efficacy is 91.6%. It's a 2-dose regimen as well, given 3 weeks apart. It's given intramuscularly. It's a combination of 2 adenoviruses called AD5 and AD26, or adenovirus 5, adenovirus 26. We have seen the results of their phase 3 trial, and it's pretty good. They are also doing a study trying to mix this with AstraZeneca vaccine to see whether the efficacy can be increased, and they are doing a single-dose version of this vaccine called Sputnik Light. And the study just wanted to see whether 1 dose of this vaccine is actually enough. Then we have the Convidecia, also known as AD5-NCoV, from the Chinese biotech company CanSino Bio. The efficacy is 65.28%, but it's only 1 dose. So I am sure if you give 2 doses of this vaccine, you will have higher efficacy. And it remains to be seen whether this will remain 1 dose. Because if you want to optimize protection, you should give 2 doses for this. But I guess this is what the company wants, to promote this vaccine as a 1-dose only dosing regimen. But we will know more as this is being used in different countries. So this has been approved by the Chinese regulators in February this year, and in March this year, they started using an inhaled version of this vaccine in clinical trials. Then we have the Sinopharm vaccine. This is, by the way, the first Chinese vaccine that's been given emergency use listing approval by the WHO. Phase 1 and 2 of Phase 1 and 2 trials have been published in the Lancet, and several countries have been using this already and have been doing their own local studies. UAE gave full approval, announcing that it had an efficacy rate of 86%, and a preprint came out a few weeks ago showing that the vaccine is modestly weaker but still effective against B1351 variant. And we will most probably be seeing more data from this company since it has been given the go signal by the WHO. Then we have CoronaVac from Sinovac. It's an inactivated COVID-19 vaccine. Of course, the main advantage of this is that it can be stored in a standard refrigerator at 2 to 8 degrees Celsius. A randomized, double-blind, placebo-controlled phase 1/2 study was conducted in China, and in those in China in 18 to 59 years of age, and also in people 60 and over, 60 and above. And the results, the trials found that immunogenicity in most patients and was good, and that the vaccine was generally safe and well tolerated. At the time of this recording, phase 3 data has not yet been published in a peer-reviewed journal, but we know that this vaccine has been used in Turkey, Indonesia, and Brazil, and they have reported vaccine efficacy in these different countries, varying from 50.4% to 83.5% in Turkey. And this is given in 2 doses, 2 weeks apart. And we know that recently Chile has reported a real-world study in the country, and it showed that the vaccine is 67% effective against symptoms. It reduced hospitalizations by 85% and intensive care admission by 89% and deaths by 80%. And that is actually pretty good as well. Then we have the vaccine, Covaxin, also known as BBV152. It's the inactivated vaccine by Bharat Biotech and the Indian Council of Medical Research in India. It is formulated with a toll-like receptor 7 or 8 agonist molecule adsorbed to alum, developed by the Hyderabad-based Indian biotech company, Bharat, in collaboration with the National Indian Council of Medical Research. Phase 1 trial results show that the vaccine was well tolerated and it enhanced immune responses. And it also had pretty good phase 2 results. And the company reported via press release that efficacy is 78% in its interim analysis of its phase 3 trial. And that was a little bit lower than the initial figures announced. That's 80%, but we will see what really is the case when they publish this in a peer-reviewed journal. And then we have the Epivac Corona, which is the second vaccine from Russia. It is a peptide-based vaccine, stable in refrigerator for up to 2 years. It's given in 2 doses, 3 weeks apart. It contains small portions of the proteins of SARS-CoV-2. The phase 3 trial began in November, and just like the first Russian vaccine, Sputnik V, EUA was given before completion of phase 3. And we are waiting for the results to be published anytime soon. And then we have the Johnson vaccine, also an adenoviral vector vaccine. It's called Ad26-CoV-2S. The efficacy is 72% in the US, 64% in South Africa, and 61% in Latin America. And this is just 1 dose. So this vaccine is using the same technology that was used in the Ebola vaccine that has been approved in 2018. And this vaccine was given EUA by the US FDA in end of February this year. So in summary, we have several vaccines that have been approved now by at least one national regulatory authority, and some of them have been given full approval by specific countries. For example, the Pfizer-BioNTech vaccine has been given full approval by Switzerland and the United Arab Emirates, and Sinopharm vaccine has been given full approval by the Chinese regulatory authority. And the ones below are the other vaccines that have been given EUA, but we are expecting that these vaccines will also receive full approval as more data comes in and more data is shared with the regulatory authorities. So it's actually good for us that we have 10 different vaccines approved for COVID. And this is unusual because we have never had this situation before where we have 10 different vaccines for only one pathogen, and we are using 4 different vaccine modalities. But the not so good news is that none of these companies can manufacture 7.8 billion doses, and most of the vaccine need 2 doses. So of course, this means that we will not have enough doses for everyone this year. Then we move on to SARS-CoV-2 variants. We know that that viruses mutate over time, some more than others, and that's just how viruses are, and that's normal. For example, the flu viruses, they change often, which is why we recommend that you get a new flu vaccine every year. And for RNA viruses like SARS-CoV-2, we actually really don't know whether we would need a booster, and this is something that scientists are following up. But anyway, we will be discussing here why this is something that we need to monitor closely. We know that if there are a high number of cases, there's increased risk of mutations, and if we have a situation where there is an increased risk of mutations, there are higher chances of variants appearing. And we know that not all mutations lead to variants, because some of the mutations are what we call the nonsense or the missense mutations, which will actually not change any of the amino acids in the protein. But if these mutations happen in a specific portion of the virus, and if they accumulate, then we will see these variants that we are now hearing a lot in the news. We know that all strains are variants, but not all variants are strains. So if you look at the cartoon here, you see the parental strain, you have mutations, and then you will have variants. If you have all these changes in the RNA, you will see variants, but it does not mean that it's already a strain, because for it to become a new strain, you need to see evidence of a change in the behavior of the virus. Is the virus transmitting more? Is the virus becoming more deadly? Is the virus able to evade antibodies produced by the vaccines, and so on and so forth? So we have different variants, and there are different possible answers to questions why these variants are emerging. First of all, it could be the inherent rate of mutation of the virus. It could be it might be happening because of fitness advantage. It can happen because of the presence or lack of immune pressure. It can happen because of intermediate hosts. So we know that coronaviruses can infect other animals as well, just like influenza, and that's one of the reasons why you can see these variants emerging. And then again, as I've mentioned earlier, if you have more infections in a community, if the outbreak isn't controlled, then there's higher chances for us to see variants. So there are different variants, and these are classified into variants of interest or variants of concern or variants of high consequence. So if you have a variant that has been associated with changes to receptor binding, reduced neutralization by antibodies, or reduced efficacy of treatments, then it's considered a variant of interest. So basically, what we should remember here is that any variant that is associated with changes that are important are considered variants of interest. And we have lots of variants of interest. As you can see, the P3 variant, first discovered in the Philippines, is considered a variant of interest. Then we have variants of concern. These are the variants that have shown evidence of increased transmissibility, evidence of more severe disease, evidence of a significant reduction in neutralization by antibodies. And at the moment, we have 4 variants of concern. We have the B117 that was first discovered in Kent in the United Kingdom, B1351, which was first discovered in South Africa, B1, which was first discovered in Japan from people in Brazil who traveled to Japan. And then we have just a few weeks ago, the B1617 or B16172, the variants that have been discovered in India. And I was giving this same talk in January this year, and during the time there were only 2 variants. So it just tells us that the more this pandemic, the more that the outbreak is not controlled, the more variants we will be seeing. Then we have the variants of high consequence. So these are the variants that has clear evidence that prevention measures or medical countermeasures like masks or vaccines or hand washing have significantly reduced effectiveness. And at the moment, there are no SARS-CoV-2 variants that rise to the level of high consequence. So that is a good thing for us. I will be just showing in the next few slides results of clinical trials, just showing us that if you look at these vaccines, so here you will see the J&J vaccine. This was studied in the US, Brazil, and South Africa, and during that time, the variant in South Africa was circulating. And if you compare the vaccine efficacy between US, Brazil, and South Africa, you will see that the vaccine efficacy in South Africa is a little lower, but it's still working. So the key message here is that the vaccine is still working. And then it's the same thing for the Novavax vaccine that was also done in the UK. The clinical trials were done in the UK and South Africa. You will see the same thing, that the efficacy in the UK is around 86%, and in South Africa it's around 60%. Of course, it shows that the variant that was discovered in South Africa seems to be able to evade neutralization by antibodies produced by the vaccine. But again, we have to look at this in in another perspective, that the vaccines are still working. If the numbers are 10, 20%, then we should be scared. We should be concerned. But that's not the case here. So this is a figure that I created a couple of weeks ago. This is just showing us all the different variants where they were first identified and the vaccines that have been tested so far, either in a laboratory study looking at the neutralization of the virus using antibodies produced by the vaccine, or in clinical trials. And you will see here that this is a very good picture, a positive picture, because all these vaccines have shown that they are still working very well against these variants. And most of these are from real world evidence. So these are studies done after phase 3 clinical trials. And these studies were done in different countries, in Israel, Qatar, United Kingdom, Brazil, Chile, United States. And then, so what is the best case scenario is that all these different vaccines that I mentioned are still working and will still work in the future. And this is showing us results in several countries, in the UK, US, and Chile, and this was in April. And you will see that even in these countries where the different variants have been circulating, you will still see a very obvious effect of the vaccine, and the vaccines are still working. So that's the bottom line message here. And worst case scenario, let's say that really that there is a new variant that's totally able to evade the antibodies produced by the vaccines. What will happen now? So the good thing is that the vaccines can be modified to match the variants if required. And this will not need the phase 3 studies anymore. So for all these vaccines that have been approved, all those 10 vaccines that I have mentioned, you don't need to do the whole phase 3 clinical trials again. You just need to do immunogenicity studies, and then they can be approved. So it's similar to what's happening with the flu vaccines. So every year when we change the strains that are included in the flu vaccines, we don't do phase 3 clinical trials. Don't do phase 3 efficacy trials for the vaccines. We just do immunogenicity studies. And so I think here, this is one of my last few slides. I just want to emphasize that, yes, the virus is changing, but the path to ending the pandemic is the same, which is get vaccinated as soon as you can, vaccinate as many people as possible. And although this is like a race, right, between vaccines and the variants, we know that we are going to win in the future, just like all the past pandemics. It's just, I think, a change of the mindset, because people are always so concerned about variants, but they're not pushing for vaccination as much as they should be. And there is a mismatch there of our concern for these variants and the efforts that we are doing to increase or make these vaccines reach people as soon as possible. And I would like to end my talk by just emphasizing that, these vaccines are like the moon landing of our generation. They're like the most significant scientific achievement of our lifetimes. And I think we have not absorbed the enormity of the importance of vaccines. And I'm saying that because when you speak to people, when you look at social media, you see that most people's comments are still looking at the weaknesses of the vaccines, or basically not appreciating the vaccines for what they are. They are our solutions to end the pandemic. And I hope that you will be more active in your social circles, in your families, in your friends, and explaining to them how valuable these vaccines are to us in our situation in this pandemic. And I hope that you will be able to convince more of your friends and families to get vaccinated as soon as they are able to get the vaccines. So thank you very much, and I will be very happy to answer your questions.
next speaker is a graduate of Doctor of Medicine at the Pamantasan ng Lungsod ng Maynila, Intramuros, and graduated with a GWA of 2.05 and ranked 7th among 81 students. She had her residency training in radiology at National Kidney and Transplant Institute and fellowship in CT-MRI at the same institution. She is a fellow of Philippine College of Radiology and CT-MRI Society of the Philippines. She is currently a radiology consultant of the Pangasinan Provincial Hospital and El Gura General Hospital and Universal Health General Hospital. Let us now welcome our next speaker, Dr. Lalaine Olivar Molinawe.
Good day, everyone. Thank you, PUA Mindanao chapter, for inviting me to be one of your resource speakers. So this is uroradiology hacks. So we, including my husband, who's also a radiologist, actually had a hard time doing this lecture because the topic cannot be lifted from any textbooks. Because of this, majority of the cases here are from our own personal experiences, and cases will be included in the discussion. So I had my residency and fellowship training, CDMRI at the National Kidney and Transplant Institute. As you can see here, we have our own separate diagnostic center building. The Department of Urology shares this building with the emergency room, oncology, radiation therapy, and some offices, as well as the PET CT scan. In our department, we do an average of about 200 to 300 x-rays daily, 80 to 120 ultrasound, 30 to 50 CT scans, 10 to 20 MRI, 20 to 30 IR procedures, interventional radiology procedures. The department is called the Department of Medical Imaging and Therapeutic Radiology. As early as our first year in training, apart from basic radiography and ultrasound, we are trained to do ultrasound-guided procedures such as thoracentesis and paracentesis. As we become more senior, we got to do nephrostomy tube insertion guidance together with the urologist and kidney biopsy together with the nephrologist. So a little overview of the topic, which I divided into different modalities that we use in radiology. Uroradiology hacks in X-ray, ultrasound, CT scan, MRI, and interventional radiology. So let's start. First, Euro hack in X-rays. Is X-ray considered a relic, or is it still reliable? At this day and age, we're always leaning to ultrasounds or even CT scan, right? But X-rays are still very useful. It's affordable, it's quick, and it has a lesser radiation dose compared to CT scan. The American College of Radiology lists at least 16 indications for KUB or abdominal X-ray. Although majority of it are for GI diseases, indications relevant to your practice include the following. Evaluation and follow-up of urinary tract calculi, including assessment of lithotripsy patients, monitoring of DJ stents, and scout field prior to procedure. Here is a KUB X-ray wherein there is a DJ stent, and in the lower inferior aspect of the DJ stent are some hyperdensities which are likely incrustations. Upon removal of the stent, multiple incrustations are seen in its inferior aspect. Now, what do you order? An abdominal x-ray or a KUB x-ray? Is there a difference? Yes, there's a slight difference. In an abdominal x-ray, the technologist, the radiographer, will try to get the entire hemidiaphragm as its superior aspect. And if it's some KUB x-ray, the pelvic cavity will be, the entire pelvic cavity will be seen in its inferior aspect. So in here, the picture on your left is an abdominal x-ray. As you can see, the hemidiaphragm is seen in its entirety, in its superior aspect. In KUB x-ray, in the middle portion, the entire pelvic region can be seen. If you have a small pediatric patient in a single film, the entire hemidiaphragm can be taken and the pelvic region can be seen in one film. So if you want to focus on the pelvic region, you should request for a KUB x-ray and not an abdominal x-ray. What if you don't have an access to a CT scan? Remember the IVP, or the intravenous pyelography. Some of the young people out here may not know this procedure anymore. During my training, I think I've had only 10 patients. I've assisted in 10 patients for KUB IVP. So nice to know that we can do this in our department. It's becoming more and more obsolete. However, it's still useful and affordable. In this patient, we can see that the right pelvocalyx is dilated with a filling defect in the middle aspect, likely due to a urothelial calculus. Moving on to the next modality, which is urohacks in ultrasound. In doing the kidney ultrasound, the kidneys is a retroperitoneal organ. Therefore, we can see it through the back. After evaluation of the patient in the supine position, we can ask them to do a lateral decubitus position for better view or for better examination of the kidneys. Now, how do we diagnose a nephrolithiasis? We diagnose a calculi or a nephrolithiasis if two of the following characteristics are shown. There is an echogenic focus with an acoustic shadowing exhibiting, or if it exhibits twinkle artifact on color Doppler or comet tail artifact. Not all echogenic focus on ultrasound are calculi. There are mimics of nephrolithiasis on ultrasound, and this includes vascular calcification, early medullary nephrocalcinosis, medullary sponge kidneys, infections, medullary fibrosis, intrarenal gases, and milk of calcium cyst. For example, this is a KUB x-ray of 45-year-old female who has been diagnosed with a middle calyceal calculus since 2018 and is routinely monitored. So I ended up with the ultrasound of the patient, which revealed a cystic focus with an echogenic focus. However, the echogenic focus has no clear posterior acoustic shadowing. If you ask this patient to do a lateral decubitus position, These echogenic focus will actually move or layer because this echogenic focus is not a nephrolithiasis, it is not a calculi, it is a milk of calcium cyst. Now, we move on to uroradiology hacks in CT scan. CT scan is the modality of choice in the evaluation of blunt renal injury. So this is an actual case of my husband. He did a few weeks ago. He was called for a fast ultrasound of a 24-year-old male, vehicular accident riding a motorcycle, hitting the fender of an SUV. Fast ultrasound was done. So this is the kidney. Does it look normal? Yes, it looks normal. So ultrasound was done, which only revealed minimal pelvic ascites in the background of a gassy abdomen. The following day, the patient experienced difficulty of breathing. There was vague abdominal pain. The abdomen was more tense, and there was decreasing hemoglobin. XLAP was done, which actually revealed a shattered kidney and approximately 1 liter of hemoretroperitoneum. So, with this, for blunt abdominal trauma, it is best to do a CT scan. Do we do it with contrast, or will a plain study suffice? It actually depends on the urgency and with the clinical picture of the patient. Contrast study will give us more information, more extent of the injury, such as ureteral injury. CT scan is better in evaluating the retroperitoneum as compared to the ultrasound. Next case, 34-year-old female who came in for a right flank pain, 8/10. Is it a renal colic pain? During the past decade, unenhanced CT scan has become the standard of reference in the detection of urinary calculi. Owing to its high sensitivity, approximately 95%, and specificity, approximately 98% in the setting. However, numerous diseases may manifest as acute flank pain and may mimic urolithiasis. Up to a third of unenhanced CT scan performed because of flank pain may reveal unsuspected findings related to stone diseases, but will eventually may help explain the patient's condition. Alternative diagnoses are most commonly related to gynecological conditions, especially adnexal masses, non-stone genitourinary diseases such as pyelonephritis, renal neoplasm, and closely followed by GI diseases, appendicitis, diverticulitis. Hepatobiliary, vascular, musculoskeletal conditions may also be encountered. Vascular causes of acute flank pain must always be considered, since these are life-threatening emergency that may require the intravenous administration of contrast material for adequate diagnosis. We must be familiar with the typical findings of urinary stone diseases at unenhanced CT scan, as well as the spectrum of alternative diagnosis that may be detected with this modality to adequately diagnose the source of flank pain. So in this patient, female patient who presented with right flank pain, the cause of it is a very large right ovarian cyst. Next modality, Eurohacks and MRI. So what if you have a pregnant patient who is complaining of a left flank pain? Ultrasound is unremarkable. What do we do next? We can do MRI urogram. In the study of Regan et al., MRI is able to correctly detect the level of obstruction in 100% of the cases, and MR urography is able to show the cause of obstruction 13 seconds within the study. This is actually a normal urogram. It is fast and accurate. No need for contrast. It has no radiation, therefore safe for a pregnant patient. However, it is more expensive and it's not readily available. So I think I'm coming to the end of my lecture. We go on to uroradiology hacks in interventional radiology. So here in the Philippines, for prostate biopsies, we usually do ultrasound guidance, doing at least 12 cores, hoping to hit the lesion. So Pokorny reported that in primary biopsy setting, MRI-guided in-bore biopsy resulted in an increase in the overall detection rate of intermediate and high-risk prostate cancers when compared to the standard transrectal ultrasound-guided biopsy. This is an image, sagittal section, showing an MR-guided in-bore biopsy using MRI-compatible needle guide and needles. Here is an algorithm proposed by urologist Dr. Peter Swindle. So if there is an elevated PSA, it is best to have an MRI of the prostate to best evaluate whether there is a targetable lesion causing it. And based in its location or an accessibility, we can decide if it is best to do a transrectal biopsy if the lesion is large and peripheral, and if it's small and anterior, then an MRI-guided biopsy can be done instead. However, in reality, in the Philippine setting, this technology is still not readily available. It is a very expensive setup. I don't know if it's being done here in the Philippines. And so we go back to the traditional trans-ultrasound guided prostate biopsy. With the radiologist, we try to target the hypoechoic peripheral areas. However, sometimes the prostate gland appears as a homogeneous structure, and all you can do are random biopsies. That's why we do a 12-core biopsy. I would just like to mention about the role of PET scan in prostate cancer, since now there are more PET scans available, and this is becoming a great tool in the oncology practice. It is gaining ground on initial screening, especially in cases with low PSA levels, and it's used in staging purposes. Types of PET scan tracer available include the Axumin, FDG, and the PSMA, or the prostate-specific membrane antigen. Here at NKTI, I think they used the PSMA, prostate-specific membrane antigen. So that ends my lecture. So what are the key points? In diagnostic, the most expensive imaging test does not always mean it is the best. We radiologists are technology driven and we are technology dependent. And I think the best hack that I can tell everyone is that don't hesitate to ask your friendly radiologist for help. Thank you, everyone. Thank you all for watching.
Our next speaker for today is graduated with a degree of Doctor of Medicine at the University of the Philippines, finished urology training program at Philippine General Hospital, a diplomate of the Philippine Board of Urology, Fellow of Philippine Urological Association and Philippine College of Surgeons, past National President of the Philippine Urological Association Incorporated, an examiner and the Chair of Philippine Board of Urology in 2020, an Associate Professor of Xavier University Jose P. Rizal School of Medicine, the Medical Director of Maria Reina Xavier University Hospital, past President of the Misamis Oriental Medical Society and Misamis Oriental Physician Nurses Foundation Incorporated, a member of the Cagayan de Oro City Local Health Board, and took units in Master in Science in Health and Hospital Management at the Xavier University 2013 to 2016. Let us now welcome our next speaker, Dr. Raul Winston P. Andutan.
Good day, everyone. First of all, I would like to thank the organizing committee for inviting me and including this very important topic, the student's path to become a urologist. I am tasked to showcase the practice of urology and inspire students to enter the exciting world of this surgical subspecialty. I believe that your idea of what a doctor does has also changed dramatically upon graduation from what you knew when you entered medical school. Many of the students now are at a loss as to what career path to choose from, hence this particular lecture. First thing first, what is the scope of urology? Well, traditionally, we define the scope by its anatomic boundaries. So, urology is a surgical subspecialty. That means urologists are surgeons. It deals with the diseases of the urinary system of both males and females, including the adrenals, and of the reproductive system of the males. Hence, it may be considered as the counterpart of nephrology in internal medicine, and it also overlaps with the practice of gynecology. But sometimes urology practitioners are not only defined by what procedures they perform, but rather by their lifestyle, by their associate and friends in life, or by their reputation. If the surgeon loves to travel, is family oriented, and does not have many surgical emergencies, but still with much luxuries in life, then most likely he is a urologist. What really attracts residents to the specialty? Well, urology is a very dynamic subspecialty because its advancement is intertwined with the progress in technology. The growth of medicine is best exemplified by the progress observed in urology. So, as surgeons, what procedures do we perform? Well, we are the pioneers in minimally invasive surgery, such as endoscopic surgeries and robotics. We started it all with our bread and butter procedure, the TURP, or transurethral resection of the prostate. Now, the landscape is rapidly changing, and PURP is being gradually replaced by laser prostatectomy for benign prostatic hyperplasia. The prostate inside a narrow pelvis is very ideal for robotic surgery. The reason why we are at the top as regards users of robot. In fact, about 70% of radical prostatectomies are done under robotics worldwide. Open surgery for kidney stones is also becoming obsolete with the advent of ESWL or extracorporeal shockwave lithotripsy, wherein we just fragment kidney stones with sound waves. And if ever we cannot fragment with ESWL, we do percutaneous puncture of the kidney under ultrasound or fluoroscopic guidance. Then do fragmentation with laser or other sources of energy. Likewise, radical and partial nephrectomies are now commonly done laparoscopically. So it seems that urologists have it all. Urology is a world of exciting procedures, and if you are so daring and adventurous, you can go into SRS or sex reassignment surgeries, or you may specialize on penile implants. You may also opt to focus on kidney transplantation, where you can do the harvesting of kidneys through laparoscopic procedure or open surgery. If ever you wish to perform the anastomosis of the renal to the iliac vessels, then you have to undergo additional formal transplant fellowship training. You may also concentrate in pediatric urology to repair hyposphagias and vesicoureteral reflux. You have a spectrum of procedures to choose from. You may wonder since when urology has been practiced. Well, the interest in urology as well as its practice is as old as the time of Plato and Hippocrates in around 300 to 400 BC, as documented by Aristotle in his treatise Definitiones Medicales. However, our national organization is relatively young, which was founded only in 1957. Currently, we are 431 members nationwide, with the majority, around 60 to 70%, are practicing in National Capital Region. In 2003, the first ever chapter of the Philippine Urological Association was created, and it is the PUA Mindanao chapter. Now there are 6 chapters of the association nationwide. The Mindanao chapter has 45 proud members, and I am privileged to mention that the chapter has produced 2 national PUA presidents. To maintain the highest standards of residency training programs, the Philippine Urological Association established in 1972 its independent accrediting and certifying arm, the Philippine Board of Urology Incorporated. It is responsible for monitoring compliance with the standards and certification of core competencies of the graduates. The need for urologists in the country may interest everyone. If we translate the 431 members as of 2021 to urologist to population ratio, Every Filipino urologist is handling a population of 250,000, a far cry from the ideal 1 is to 20,000 ratio. In Mindanao, which counts for about one-fourth of the total population of the country, the ratio of urologists to population is as high as 1 is to 600,000. Hence, there is a big demand for urologists, especially in Mindanao. So, what academic background does urology residency require from you? It is not so much of your initial medical knowledge after graduation that will guarantee the success of your future clinical practice, but rather from what you will learn during your residency training program. Although a strong background in anatomy, physiology, and pathology may help. The four basic core competencies that are expected to be acquired by every graduate are medical knowledge, surgical motor skill, focused on minimally invasive procedures, communication skill with your patients and colleagues, and lastly, professionalism. The core competencies are expected to be translated to the basic attributes of being a Filipino urologist. The graduate must be a competent and safe clinician, possessing a defined body of knowledge and procedural skills, who is able to make appropriate clinical decisions. As a leader, he must be able to handle positions in organizations, be it in the hospital or professional one. As a communicator, he or she must be able to establish relationship with patients and colleagues. And as a team player, he or she must be able to collaborate with a multidisciplinary team and recognize the importance of this approach of patient care. As an academic, he or she must be able to recognize the need for continuous learning. As a professional, he or she must be an ethical practitioner. And as a health advocate, he or she must be able to contribute to improve health systems. The entire training in general urology consists of 1 to 2 years in general surgery and additional 4 to 5 years in general urology proper. There are now 2 institutions which have implemented the 1+5 program, meaning 1 year of general surgery instead of 2, and 5 years of general urology. This is to focus more on minimally invasive procedures. And where do you wish to train? Well, entry to general urology residency has become very competitive. Currently, there are 11 Philippine Board of Urology accredited training programs and 3 Philippine Board of Urology recognized training programs. The latter refer to a structured program without accreditation yet. A requirement for application for eventual accredited training program. Our very own Northern Mindanao Medical Center in Cagayan de Oro City has just applied for recognition and is scheduled for inspection in December this year. The 11 accredited institutions are producing 20 to 25 graduates per year. So where in NCR? Well, in NCR, UPPGH is still the premier institution, but the other training institutions are fast catching up. The various institutions have their own respective strengths, like UPPGH with its high volume and variety of cases, and is the only government institution with a robot. NKTI, or the National Kidney Transplant Institute, has its transplant exposure, and laparoscopic and endourology as advantages. UST, on the other hand, has pediatric urology and urodynamics as its forte. East Avenue Medical Center has endourology and laparoscopic surgery, plus rotation in Vietnam as advantages. Jose Reyes Memorial Medical Center has also the variety in volume of cases as its strengths. Veterans Medical Center has TURP as its strong point. How about training programs in the provinces? We have two each in Luzon, Visayas, and Mindanao. Vicente Soto Memorial Medical Center in Cebu has its first graduate here with us in Cagayan de Oro. Likewise, the training officer of the soon-to-be-recognized program in Northern Mindanao Medical Center is also with us. Presently, SPMC, or the Southern Philippines Medical Center, where the majority of its consultant staff are NKTI trained, is the nearest accredited training institution to Cagayan de Oro City. The Philippine Board of Urology encourages collaboration among training programs to complement each other. So you can choose anyone because they are now almost equal. They have their respective strengths. How do you become board eligible, which is defined as being able to take the certifying diplomate exams? Well, you must have trained for at least 6 cumulative years, inclusive of general surgery, all in accredited training institutions. You must have complied with the required number of cases and research papers. Equally important is you must have passed the basic and clinical resident in service exams, as well as the practical PURP exam. The latter is given to graduating residents who have complied with the required number of TURP cases. The Philippine Board of Urology is not only concerned about the clinical competence of the graduates, it likewise puts much emphasis on the ethical competence, and attendance in seminar on professionalism is mandatory prior to conferment of diplomate status. Once you have become a diplomate of the Philippine Board of Urology and you wish additional training, you may decide to undergo fellowship training in any of the popular subspecialty fields. Well, NKTI offers urologic oncology fellowship, while East Avenue Medical Center offers fellowship in endourology for stones. Well, to all interested students, I advise you to grab the opportunity to be famous and respected, pursue a clinical practice where you can enjoy a full life. So I advocate, I advise that everyone, every student, or most of the student or top of your class students join the urology family. Thank you for your attention.
Our next speaker earned his Doctor of Medicine at the St. Luke's College of Medicine, William H. Quasha Memorial. He finished his residency at the Anatomic and Clinical Pathology Institute of Pathology, St. Luke's Medical Center. He then had fellowship training in urological genitourinary pathology at Department of Pathology, the Johns Hopkins Hospital, Baltimore, Maryland, USA, under his mentor, Dr. Jonathan I. Epstein. He then presented and had numerous lectures from various societies, institutions, and hospitals locally and abroad. He is the current chairman of the Department of Pathology, St. Luke's Medical Center, College of Medicine, William H. Quasha Memorial, and section head Histopathology, Institute of Pathology, St. Luke's Medical Center, Quezon City. He is the past head and chairman of the Institute of Pathology of the same institution. Let us now welcome our next speaker, Dr. Jeffrey S. So.
Good morning. I just want to thank the Philippine Urological Association for inviting me to lecture at the Urology Practice Hacks 2.0. So I'll be tackling common dilemmas that are usually encountered between urologists and pathologists, and sometimes we have some form of miscommunication and want to clarify those. So this will be the outline for the lecture. I have 6 topics. Hopefully at the end of the day, I'll be able to clarify some things and we'll have better communication between the urologist and the pathologist. So we start out with diagnosing small foci of atypical glands that we try to diagnose as prostatic adenocarcinoma. I always start out with the normal histology of the prostate, and this is what we usually get. We get simple glands that sometimes are undulating, that have two cell types. Commonly, you have your basal cell and, of course, your luminal cell. There are certain pathognomonic features when we're talking about prostate cancer. And when we say pathognomonic, these are absolute indicators of malignancy. You don't see it in any form of any benign entity. So it could either be perineural invasion, which most urologists would know would also be an indicator of a higher chance of extraprostatic extension. But for most pathologists, if you see a nerve bundle such as this being surrounded by glandular proliferation, that really favors or is an absolute indicator, again, of malignancy. Next would be glomeruloid formation. For most pathologists, when we have this cribriform structure attached to one point to the wall of an atypical gland, this is automatically cancer. And this is also automatically pattern 4 or Gleason pattern 4 cancer. You can also have mucin extravasation. Normal prostatic glands will not produce mucin. So if you have mucin, even if it's intraluminal, then you're suspicious for cancer. But they're absolutely cancerous if all of that mucin, which we see here, this violet material, goes out into the surrounding stroma. Then that would be malignancy. Next is mucinous fibroplasia, which is related to mucin extravasation. You have these fine fibrillary areas that are a reaction to the foreign body material. In this case, that's mucin, inducing this collagenous sphere nodules, which is the other name for mucinous fibroplasia. And again, an absolute indicator for malignancy. The problem with most of these cases is that you frequently don't see any of these features. You only see them in about 5% of prostatic adenocarcinoma cases. So where do most pathologists rely their diagnosis on? They rely their diagnosis on the softer features of prostatic adenocarcinoma. That's why it's a very delicate balancing act in trying to figure out if you do have malignancy or not, especially in very small focus. So what happens if we're not sure? We tend to call them certain terms. These are your borderline lesions. I tend to prefer atypical gland suspicious for carcinoma over ASAP, but they're one and the same. Why do I prefer atypical glands? Because it does not connote, it doesn't imply that it's like an absolute diagnosis. We're basically saying we're not sure. It could either be malignant or it could be benign. Most pathologists would be 50-50. Second, if I just say atypical glands, I can further explain why they're atypical. Oftentimes I would write or include in the surgical pathology report the reason why it's atypical. I would say, I can't rule out high-grade PIN, I can't rule out adenosis, or I can't rule out atrophy. Okay? Making the diagnosis of atypical glands easier to explain. So based on literature, an atypical diagnosis or ASAP should be rendered in about 0.7% to 23.4% of cases, with an average of approximately 5%. That 5% is usually for our super experts. I can't get that low. Based on is it being rendered judiciously or warranted in our country, I made a study with one of my mentors before leaving for fellowship, and we were able to find out that before I came back in St. Luke's, we were rendering about almost 31% of our cases as atypical. That's about 1/3 of cases. And that's pretty high, which is contradictory to what should be diagnosed as atypical in literature. And among these atypical diagnoses, only 27% turned out to be cancer. That's a pretty low number. So when I came back, we tried to actually improve on diagnosing and being judicious in diagnosing atypical glands. And we were able to do that. How did we do it? We tried to actually check all of our pre-analytical variables. So we have to make sure that you're using buffered formalin. Easier said than done. Some laboratories don't buffer their formalin, so it's not 10% buffered formalin. What happens is that your tissue is overfixated, making cutting of these paraffin blocks very difficult for our medical technologists. So instead of having a 2 centimeter tissue, what's left of you is about 1 centimeter. And if that area that was pretty overfixed is not cut properly, we may miss the area of cancer. And of course, if you buffer it properly, antigenic expression for immunohistochemical staining, such as PIN4, will be easier and more optimal. Next, you separate your cores ideally in individual containers. Nowadays, versus a few years ago, a lot of you now are really separating them in their individual containers. So multiple cores, it helps that we can have multiple planes of section. We don't consume, again, the focus of prostate cancer. You have to remember, if you're putting like 5 cores in one paraffin block, this is for our medical technologists, then your tendency is you might overcut some of those tissues. Again, you might overcut the focus of cancer. And if there's an atypical diagnosis, it's easier to do a repeat if they are in their individual containers. For example, instead of just saying it's in the left and right lobe, you're able to say it's in the left posterior apex. So if there's a saturation biopsy needed or a repeat biopsy needed, most of you can go back to that particular area and saturate that area instead of just saturating the entire left or right. Do deeper step section. Some pathologists would not do this because they're afraid that they have such a thin tissue. But I found out that if you do step sections or deeper section, it saves a lot of money, especially to the patient. You don't need any immunohistochemical stains. And of course, as a pathologist, you should be able to recognize common benign mimickers of prostate cancer, such as atrophy. It could either be partial, post-atrophic, or even simple atrophy, adenosis, high-grade PIN, and central zone histology. All of these I see in my practice, especially when I get consult cases being diagnosed as atypical. If you're used to seeing these lesions, you lessen the chance of you rendering an atypical diagnosis and giving anxiety to your patient. One of the last ones that we could usually utilize would be using immunohistochemical stains. Those of you that send consult cases to me know that I really use stains in order for me to actually diagnose small foci of prostate cancer, especially those who are candidates for radical prostatectomy. So in the traditional method, you have P63, high molecular weight CK, and Amacar as separate stains. But now we're fortunate enough that we had the cocktail PIN4. What's the advantage? Before, we had 3 stains, 3 separate slides. The problem with that, on the 3rd stain, you might actually overcut the tissue and you're left with nothing. No more atypical focus. And that renders the staining mood and academic. So you're again left in a typical diagnosis. But now, because of the PIN4 cocktail stain, which you have here with different colors indicating the different stains, we as pathologists are able to actually diagnose them in a single slide. Less chance of overcutting the tissue. So again, they're the same price. The difference is that we are able to render our diagnosis easier in one or in a single slide. And of course, the last option, even for me, some would consider me the last option when it comes to atypical diagnosis. Personally, if I still have a difficult time diagnosing a small focus as prostate cancer, I still seek help from a second opinion from a colleague. Never hurts to show your case to another person. And of course, we could do repeat biopsy. I usually suggest a repeat biopsy for cases when that focus is too small for me to actually do immunohistochemical stains. I don't force it because I always have to remember that immunohistochemical stains are just a supportive ancillary procedure for me to diagnose prostate cancer. They're not the end all be all. So if I call anything atypical, usually I'm about 80 to 90% sure that is prostate cancer. I just want to have a little more help in diagnosing it just because, especially for those people who are pretty young and will undergo radical prostatectomy. I don't want to be surprised and suddenly you don't have anything on your radical prostatectomy specimen. So the average risk of cancer following an atypical diagnosis is about 41% with a median of 38.5%. So next would be proper Gleason scoring. All of you know I've been lecturing this for so long, and I still see some suboptimal Gleason scoring on some of my consult cases. So as a review, this is the one on the left is the classic image of your Gleason scoring. Of course, it's not terribly different from any grading system that you have with other tumors. But the novelty of this, of course, is that you have numbers. Okay, a lot of the changes have occurred in pattern 3 and pattern 4. So this is the progression or the evolution of your Gleason scoring system. In 1991, about 1/4 of pathologists rendered a diagnosis of Gleason score 2 to 4, decreased to 2.4% in 2001, and currently it's 0%. I'm glad to know that here in the Philippines, I'm seeing less and less people diagnosing Gleason 2 to 4. It's about less than 5 to 10% my consult cases now, versus when I was doing or starting my practice, about 1/3 of people were still diagnosing Gleason patterns 1. Just as a reminder, of course, and I'm pretty sure most of you urologists would know, versus pathologists, they don't know this much, but a pure Gleason 6 cancer should not metastasize. So the traditional scoring method would incorporate the most common pattern as the first pattern, and the secondary pattern would be the next most common pattern. Very logical, easy to do. However, this does not take into consideration the fact that you can have a third pattern present within the 4. So what do we do now? If you have a third pattern present, the primary is still the most common pattern, and the secondary would be the worst pattern left. As an example, if we have a 4, such as this, the blue area, the 60% Gleason pattern 4, that remains the same. It's the most common or most commonly prevailing pattern. And the secondary pattern would be either pattern 3 or pattern 5. So even if pattern 5 is only 10%, now in the updated scoring, this would be 4 plus 5 equals 9. Before this was called 4 plus 3 equals 7. And as we all know, 4 plus 3 equals 7 and 4 plus 5 equals 9 have a very different cancer-specific survival. So this is a contemporary prostate cancer grading system, a new supposedly grading system, but now it's been out for a lot of years now. But it started out the Hopkins group, and it was based on almost 20,000 cases from a large cohort from Johns Hopkins, Memorial Sloan Kettering, Karolinska, University of Pittsburgh, and Cleveland Clinic. It accurately stratifies prognosis and still based on the principles of the Gleason scoring system. Why is there a need? There's patient benefit. Easier to explain to the patient, of course. It's a spectrum of 1 to 5. Versus, for example, with the too many permutations of your Gleason scoring, you have more than 20 permutations, 1 plus 2, 2 plus 1, 3 plus 3. It's easier to explain now. Assumed behavior for various Gleason scores is not accurate. It does not take into consideration some of the variants of your prostatic adenocarcinomas. And it's more of a prognostic grade group. So as we all know, and I always put this after my report, if I have any malignancies, it's divided into 5. Before, a lot of us thought that Gleason 7 was homogeneous, same behavior. But as we all know, most studies some studies would actually include 3 plus 4 equals 7 into your active surveillance protocol. So these are just your Kaplan-Meier curves showing again the division based on biochemical recurrence-free survival of your 5 prognostic grade groups. And it's the same across the board when it comes to biopsies and your radical prostatectomy specimens. So I was fortunate enough to be included in this white paper by the Genitourinary Pathology Society. And it actually encompassed a lot of the grading and the contemporary grading that we do now, answering some questions that we have with all the developments that we've had in prostate biopsies. Okay, specifically MRI targeted prostate biopsies. It's far superior to systemic prostate biopsy for identifying high-grade prostate cancer. So as a caveat, we all know that a minority of cases may be, high-grade tumors in a minority of cases may be missed. A consensus statement by the AUA and the Society of Abdominal Radiology recommends that at least 2 cores are obtained from each MRI suspicious lesion. In order to prevent tissue fragmentation, it was also recommended that no more than 2 cores are placed in a single container. So hopefully we can do this moving forward. A particular problem that we have, and we're talking about MRI targeted biopsies, especially for pathologists, would be if we have multiple cores or multiple fragments in a single container, which can happen. Some of you I know actually take a lot of areas in the suspicious, let's say, PIRADS 5, PIRADS 4 nodule. And in this case, if it turns out to be malignant, there's a conundrum for us pathologists. If these are the cores that I got from that container, and I see all of them bearing malignancy, they could have different lesion scores. The question here is that, what do you do? Do you do an aggregate or the individual highest lesion score? There is no current recommendation from actually our society. It's more of a consensus. Some studies have shown nice results, but still some contradictory results. I'll just tell you what I actually do, and hopefully it is appropriate for your practice. I know from the traditional stance, we usually actually go for the highest lesion score. However, as you can see here, it's pretty obvious that you have more 3 than the 4. So if this was the individual highest score that we're taking, then we have a Gleason 8. However, in aggregate, this would be Gleason 3 plus 4 equals 7. Based on my experience, and this could be purely anecdotal, the tendency is if you do radical prostatectomy cases in this specimen, you would get a Gleason score 7 rather than a Gleason score. However you want to interpret that, I leave it up to you. There was a nice study actually showing some different results when you're trying to define which is the optimal method for reporting prostate cancer grades on MRI-guided biopsies that are frequently fragmented. It was a study from Dr. Gordetsky, and it compared an aggregate reporting method versus an individual core reporting method. And based on her results, it showed that aggregate better predicted extraprostatic extension, but it's still inconclusive in the final grade. I'm pretty sure, and I know Dr. Gordetsky, they will do follow-up studies on this. So hopefully they could clarify more if using the aggregate would be more concordant when you're dealing with your radical prostatectomy specimens. So the current consensus would be report the grades of each core separately as long as they are submitted in separate containers, or the cores are in the same container yet specified by the urologist as to their location. Different ink, different colored inks. In the setting of multiple undesignated cores with cancer in one container, an overall grade, which I do currently, is given for the cores in a specific container, as if all the involved cores were one long core. And when multiple undesignated cores are taken from a single MRI targeted lesion, report the aggregate grade, total number of cores involved by cancer, and overall aggregate tumor extent. So next would be dealing with poorly differentiated carcinoma of the prostate or the bladder. I think those urologists who've gotten some of the reports from me, even if you say it's from the bladder tissue or prostate tissue, if I see something so poorly differentiated, never giving a hint that it's actually glandular or urothelial, I tend to just say I just tend to give a diagnosis of poorly differentiated carcinoma, and I request for stains. We all know that the urinary bladder is known to be commonly involved with tumor extension from adjacent organs. Though the prostate is not commonly involved with metastatic lesions, bladder tumors commonly extend to the prostate, which we have to rule out. So this is an example of a bladder tumor that is supposedly, we tend to think that it's immediately from the urothelial lining. However, as I'll show you here on the right side, this is your urothelial lining, and there is no exophytic lesion. There's no papillary lesion. Second, there's no atypia that may indicate that you have an in situ carcinoma. All you have are these nests and sheets of neoplastic cells invading the lamina propria and most probably the muscularis propria. So the picture here shows that most probably the tumor is coming from outside rather than from the overlying urothelial lining. That tends to favor something as metastatic or tends to favor something that may be from the prostate if the patient is male. So we use stains. These are the frequently requested stains that I ask for. GATA3, a urothelial marker. It's a bit promiscuous, meaning it can stain for a lot of tumors. But when you're talking about just prostate versus urothelial, it has a pretty high sensitivity and specificity rate, 80 to 90%. So there's a good internal control here showing positive staining by the brown stain. That's your urothelium. So that's a good indicator that it's working. And all of the lesion that we're thinking of as urothelial is negative. Another stain that we could use would be high molecular weight cytokeratin or even P63. They're positive here, the high molecular weight CK, and it's negative on the atypical focus. So we use PSA to try to check out if it is indeed prostatic. So what we see here is there's a slight blush. It's not so intense. Why? Because it's poorly differentiated. I frequently see a lot of tumors that are poorly differentiated, supposedly from the prostate, that don't express PSA anymore, even at the serum level. So that's why this next stain, which is pretty new, is your NKX 3.1, is highly valuable. Because even if your PSA is negative, you can actually use it to indicate prostatic etiology. As we can see here, it's a nuclear stain, it's positive. So that favors a prostatic tumor involving the bladder. Another stain that you could use, which we don't use anymore, is prostine just because of the lack of demand. But it's also an adjunctive stain that I used before when we still had the supply. So another example would be a prostate tumor. Some would go hook, line, and sinker and think that this would be something that is prostatic and just call it Gleason 5 + 5 = 10 prostatic adenocarcinoma. However, as you can see, you don't see any glandular architecture. So you have to be suspicious that this might be coming out from another site, particularly the bladder. And we stained it, and all of the prostatic markers are negative. What were positive were the urothelial markers. So this would be infiltrating high-grade urothelial carcinoma involving the prostate. So what are my recommendations or conclusions? If dealt with a poorly differentiated carcinoma on either prostatic or bladder biopsy, it is highly recommended to subject the tumor to an initial panel of stains. Even if it's said to be prostate and you're highly suspicious for something prostatic, if it's poorly differentiated, I will ask for at least 4 of these stains. Commonly, I ask for PSA, NKX 3.1, GATA3, and high molecular weight cytokeratin. Next would be diagnosing high-grade PIN. So in the Philippines, it's seldom reported, and when it's reported, it's sometimes reported in the obsolete manner that it shouldn't be done anymore. It's often unrecognized and frequently misdiagnosed. It's present and this is pretty consistent, in about 5 to 8% of TRUS biopsies. So what is PIN? It's architecturally benign prostatic glands lined by cytologically atypical cells. The easiest way that I explain it to my residents is that they look malignant, meaning the individual cells, but the architecture is totally benign. Okay. High-grade PIN and cancer share the similar chromosomal anomalies like telomere shortening, alterations, members of the BCL2 genes, etc. It is not CIS because it has a lower rate of progression as compared to other organs. We do not report low-grade PIN, poor reproducibility, and there's no clinical significance. The only time I report low-grade PIN is that when someone calls it high-grade PIN, I try to help him out and say that it's more of a lowish grade PIN than true high-grade PIN. The only difference between low-grade PIN and high-grade PIN is that it should have, meaning the high-grade PIN has a large prominent nucleolus or nucleoli. How prominent should it be? For us pathologists, it should be visible at 20x magnification. Okay, these are examples of high-grade PIN, the ones on top, and this is low-grade PIN. So what we're looking for are these dot-like structures, which are your nucleoli. If we see them at 20x magnification or 200x, including 20x magnification, then that will be a diagnosis of high-grade PIN. Just to further emphasize those nucleoli that we're looking for. So most studies have shown if there's only one core positive for high-grade PIN, it does not help predict which men are at higher risk of having cancer, even if you use your PSA, age, and family history. It doesn't help. Of the 22 studies of the risk of cancer following a diagnosis of high-grade PIN on one core that were published in 2000 or year 2000 or later, there was about 24.1% chance that you would have cancer in the subsequent biopsy, versus the average risk of finding cancer in a repeat biopsy following a benign diagnosis would be about 20%. So there's no great statistical significance versus one core of high-grade PIN, repeating it with a repeat biopsy, versus one with a benign diagnosis and you repeat the biopsy. When does high-grade PIN then become significant? It becomes significant when you have more than 2 cores of high-grade PIN, even in the same location, as long as they're 2 separate tissues. There, it's reasonable to recommend repeat biopsy because the chances of finding cancer in repeat biopsy would be increased to 30 to 40%. So the recommendations when it comes to high-grade PIN would be men do not need a routine repeat needle biopsy within the first year following the diagnosis of high-grade PIN on one core. If it's multifocal high-grade PIN on biopsy, repeat the biopsy 2 to 6 months after to reduce the chances of overlying inflammation actually inducing a reactive change mimicking high-grade PIN. It's reasonable to repeat biopsy at 2 to 3 years after limited one-core high-grade PIN since we don't know the long-term risk of cancer and medical-legal issues if the patient is not followed up. These are the sources for that. And second to the last would be the assessment of depth of invasion when it comes to invasive urothelial cancers. So urothelial cancer can be invasive, as we all know, and this means that it's beyond the basement membrane. As a pathologist, it's pretty difficult for some to diagnose invasion just because we see so much fragmentation when you submit the specimen to us and a lot of coarse thermal artifacts secondary to pottery. So I personally teach the residents and tell them that even if it's fragmented, you can actually see if it's invasive or not by relying on 4 histologic features. First would be single cell infiltration. This is the overlying epithelium. And if you have single cells or small nests, that's favoring, again, invasion. If you have this retraction artifact, meaning a space around a small nest of cell, that also favors that this is something invasive beyond the basement membrane. Once the cells mature to the bottom, meaning paradoxical maturation. Why paradoxical? Because the tumor should be, or the cell should be maturing to the top, not to the bottom. Excuse me. So if you have this, then that's also an indication of invasion. And lastly, it would be desmoplastic reaction. If you have this reaction to the surrounding invasive focus, then that again favors invasion. A potential pitfall for invasion would be urothelial tumors with involution or prominent inverted growth pattern. What does that mean? Some of the tumor may actually involute, just like your Schneiderian papilloma of the nasal cavity, and actually have large nests pushing into the lamina propria, but never going beyond the basement membrane. I personally report this as, for example, this is a non-invasive low-grade papillary urothelial carcinoma with prominent inverted growth pattern. I've seen some slide review consult cases given to me or sent to me, and these were called invasion. If you don't see the 4 patterns of invasion that I mentioned a while ago, even if you seemingly see a lot of these nests of cells within the lamina propria, this is still not invasion yet. Another potential pitfall would be overcalling muscle invasion. And as personally, as I've seen in my practice, with all the cases that I've seen regarding muscle, you always ask me if you had muscularis propria in the sample that you gave me that you indicated as deep muscle bite. So for me, in order for me to call this as muscularis propria, I have to see thick muscle bundles such as these. When I see just thin wispy muscles such as what I'm showing you here on the top, those would be muscularis mucosae. So again, I have to see these thick muscle bundles in order for me to call it the detrusor muscle or muscularis propria. Again, to further highlight that, you see these thin muscle bundles, that's your muscularis mucosae. If I say propria, then I'm seeing these thick muscle bundles, the detrusor muscle. So this is just an example of a plasmacytoid type urothelial carcinoma invading the detrusor muscle. Another example, so you have these small cells, seemingly innocuous, seemingly inflammatory cells, but these are actually, again, plasmacytoid or rhabdoid type of urothelial carcinoma invading these thick muscle bundles of your detrusor muscle. And the last would be dealing with glandular neoplasms of the urinary bladder. Glandular neoplasms of the urinary bladder are a broad spectrum of lesions. If you're male, you can have lesions from the prostate and gastrointestinal tract. If you're female, some of the gynecological lesions can extend to the bladder. Then they can either be, of course, primary or metastatic. We do have primary glandular or adenocarcinomas of the bladder. They can also be a focal component. Some urothelial carcinomas can have focal glandular differentiation, or they can also present as an in situ lesion. Invasive adenocarcinoma primary tumors of adenocarcinomas of the bladder represent around 2.5% of all malignant bladder tumors. As with other variants, they arise from divergent differentiation in urothelial carcinoma. Clinically, adenocarcinomas of the bladder are usually single discrete lesions. This is a fine example of adenocarcinoma. You don't see the transitional architecture that you associate with urothelial lining. You have these glandular structures invading, even having an in situ component. When I see an in situ component, that usually favors that this tumor is primary vesical or primary urinary bladder in etiology. If I don't see any in situ lesion, that makes me suspect that most probably this tumor can be arising from adjacent organ tissue. So this is just a summary. I know it's a busy slide of the stains that we can actually utilize in actually differentiating between adenocarcinomas of the colorectal region and your urinary bladder. Why? It's because most of the tissues that we get from adenocarcinomas of the bladder really look morphologically similar to your gastrointestinal type. And the only thing that can usually be of help would be your beta-catenin. Even then, it's poorly reproducible. That's why oftentimes I don't usually use stains. I usually call you up and ask you if you've done any GI clearance or colonoscopic surveillance in order for us to rule out a colonic malignancy. If the gastrointestinal tract is clean, I would usually say that I favor a primary bladder adenocarcinoma over a metastatic lesion from the colorectal region. So again, I tend to actually shy away from using immunohistochemical stains. That was my last slide. Again, thank you. Thank you to all the organizing committee. Hopefully, this clarified a lot of things. And have a nice day. Stay safe.
Our next speaker is a graduate of University of Santo Tomas College of Medicine and is currently an associate professor of the Department of Medicine and Faculty of Medicine and Surgery at the same institution. He is a fellow of Philippine College of Physicians and a past president and fellow of the Philippine College of Chest Physicians and Philippine Society of Sleep Medicine. Let us now welcome our next speaker, Dr. Patrick Gerald L. Moral.
Good day, everyone. It's my honor and privilege to be invited as a guest speaker for the Philippine Urological Association Mindanao Chapter Postgraduate course. I've been asked to speak to you today about how to apply ethical principles in the practice of telemedicine. I don't know how many of you have been doing teleconsults, but I've been doing this over the past 15 months. And it's been a challenge, but it's also been a privilege to be able to offer this to our patients during the time of a pandemic. It may have been more common here in the NCR or the National Capital Region, but we do have a lot of colleagues who still do not want to make use of telemedicine. And perhaps, understandably, there are issues that we have to consider. In the next few minutes, allow me to discuss to you telemedicine and the accompanying ethical issues that we have to answer. And I do hope I will have some time at the end to be able to answer some of your queries. But just in case that is not available, you may message me and your questions over Twitter at Eric Moral. For any disclosures, I do not have any conflicts of interest for this part of our the discussion, right? So let me start off with a sample case. You have a patient here who is a 50-year-old who presents with dysuria for the past 2 weeks. The patient has also noticed decrease in urinary stream, and the patient claims to have a urethral discharge but denies any recent sexual activity. The patient contacts you via mobile and asks you to prescribe an antimicrobial. In the normal or usual setting, we would ask this patient probably to go to the clinic so we can do adequate history taking, an actual physical examination, probably do also a digital rectal examination on this patient to check on his status of his prostate, and then afterwards do some specific lab requests and then give him appropriate treatments or prescriptions. However, can we make use of telemedicine and to handle this particular issue? Remember that teleconsults are actually a part of telemedicine, which is a term that is more encompassing, which means it is a practice of medicine, whether it's in terms of consultations, health education, interaction between patients and doctors over telecommunications or via technology. Can we actually get an adequate history and the physical examination via a teleconsult? And is it safe enough to prescribe medications and request for diagnostics? So we will try to see whether these are applicable, and we will try to ask some questions that hopefully we can answer. There are certain expectations when we talk about teleconsultations or telemedicine. As I've said earlier, it is a practice of medicine over a distance. Now, it's not simply making a diagnosis over the internet or over technology, but it's also deciding on interventions, therapeutic decisions, and of course, making subsequent therapeutic recommendations. And we base this on data that is forwarded to us or given to us by the patient, or including documents or any other information that is transmitted via the telecommunication system. Now, there are certain challenges that we face in that. Are the standards of practice via telemedicine different, or are they similar to what we do in the real clinical setting or the face-to-face setting? And in terms of the information that we get, is it really enough, or is it sufficient for us to be able to propose diagnostic and therapeutic options to our patients? Remember that we may be hampered in the physical examination, as we will be describing in the course of the discussion. Now, another expectation is that basically this is not something that occurs just between a patient and a physician, but this can also occur between two physicians, just like a referral. So patients may be, information may be discussed over the internet, and they can be learning that can occur between two health professionals. But the challenge here is that, are we sure that we are observing the duties of care online that we should be observing for patients in the practice of telemedicine? Now, another expectation is that This is basically done for patients who cannot see a physician timeously because of many reasons, like inaccessibility due to distance. An example also will be during the quarantine, where patients were not allowed to go out of their homes. This may be due to physical disability. Employment may prevent them from taking time off from work. Family commitments, including caring for patients and others, patients' cost, as well as physician schedules. The question that I think that has to be answered, or that begs to be answered, is that, is this an adequate replacement for face-to-face consultations? Now, probably this is one of the challenges that is very significant in terms of the Philippine setting, is that it has the ability to democratize healthcare. That means patients in the most remote areas of the Philippines, as long as there is access to the internet or via technology, can actually now secure healthcare, whether it's primary healthcare or specialist care, because of telehealth or teleconsultations. And this has really the potential of improving healthcare. But as we know, technology has its attendant costs. So are the patients with limited access here given equal opportunities to utilize telemedicine? And this is where we speak of justice. Now, let's differentiate between medical ethics and the ethics of care. And I'd like to emphasize that when we talk about telemedicine, we'll focus on ethics of care. So generally, if you've heard me lecture on ethics before, it focuses on the universalizability of ethical choices and abstractions of particular patients and situations. So it focuses on that, compared to ethics of care, which talks about the uniqueness of every human being and the particularity of their own situation. So each situation is going to be unique, and we cannot box them into one specific category. So just to summarize, also for medical ethics, it focuses on freedom, and we talk here about autonomy. It's focused on the patient. It focuses on cure, fighting disease, as well as vulnerability. And it approaches human beings as independent individuals. While on ethics of care, it talks about relations. That means there is a dependence, and relationships may be asymmetrical. Despite our attempts to make relationship equal, there will always be that imbalance, in that there is always that view that the physician is held higher compared to that of the patient. So we must be aware of that. And we have to understand that human beings per se are vulnerable, especially patients. And it is important at the end of the day that these interpersonal relationships need to flourish, because we are basically relational beings. So we will focus on how we apply that in telemedicine. Now, what we'll do is I'll give you some questions, and I'll give you probably a few seconds to ponder and think whether the answer to this question is yes or no. And hopefully this will allow you to have a better understanding of whether telemedicine is something you can make use of in your practice. So my first question is, should all physicians know about telemedicine? Yes or no? So think about it. All right. So if we look at our PMA Code of Ethics, it says here that a physician should be dedicated to provide competent medical care with professional skill, full professional skill at that, in accordance with the current standards of care, compassion, independence, and respect for human dignity. So what do we want to focus on here? That means our professional skill is practiced in accordance with current standards of care. And during the pandemic, we knew that patients were sidelined by the COVID cases, and these patients needed to be seen, especially our chronic patients. So part of the current standard of care means to be able to deliver health services, and that is part of that will be telemedicine. So should we know about telemedicine? Then the answer here would be yes, because as we said, it must be in accordance with current standards of care. And part of the promise to be professionals, when you say promise, it means a promise to acquire it and maintain and advance. One is an ethical value system. And here is where telemedicine comes in: knowledge and technical skills, as well as interpersonal skills. Now, just to differentiate, how do we make sure that we are digital professionals? Because I'm sure all of you are listening to me via the internet right now. So basically, you are engaging in some form of digital telemedicine, where you're educating yourself via technology. So we have to be digital professionals. And what should we do? So we would at least want to make sure that we talk about our proficiency, our reputation, as well as our responsibility. So for proficiency, we have to make sure that we maintain an appropriate competence in selecting the technology. So we have to know how to use the technology, but we have to be mindful of the security, including the possibility of a lack of privacy and confidentiality by this technology. We have to make sure that we maintain our appropriate online professional presence and guard any digital attacks and behave online as professionally as we would do in real life. Sometimes there is a tendency to be disinhibited online because there is no actual patient or face that we see in front of us. The responsibility is we have to model positive behavior and maintain appropriate professional boundaries when communicating with our patients. And I'll show you one example where that becomes a challenge. We have to make sure that we don't waste the resources of our patients and ourselves online by not being prepared, and be careful in terms of safeguarding data. And we have to be careful about making public anything that we would not be comfortable with, and we should never forget that what happens online stays online potentially forever. And we must never engage in any illegal or inappropriate behavior in any digital medium or behave in a way that is considered as reckless or ill-mannered. All right, so this was a study in India, and they tried to identify some of the issues that could be identified with telemedicine. It was divided into clinical, administrative, and technical. So their question was that, would the care provided here be less than ideal because of possible misinformation? Now, can we practice across borders? So can I see patients in Mindanao, and can a doctor in Mindanao see patients in the NCR? Now, in terms of the provision of care, do we have to receive special training to do telemedicine? Now, we also have to have the availability of emergency support, and we'll focus about that when we talk about off-hours resources. There's a bias towards the best connected demographic, so maybe older patients or those who are underprivileged may not have access to telehealth, and we have to make sure that whatever we use in terms of monitoring can be used by everyone. Now, other issues that are involved here is that we have to make sure that the devices we use are interoperable. That means it is accessible by most of our patients and that our patients accept this technology. Now, I would want to focus on personnel in that the challenge here is there may be a loss of interpersonal relationships, and there may be a loss of respect of timelines, like boundaries may be blurred, like calls for help on a 24-hour, 7 days a week basis. And of course, reimbursement will always be one of the questions. How do we handle reimbursements, or can we be paid for our teleconsults? So, as we mentioned, if we look again at our PMA Code of Ethics, Section 3 dictates that physicians shall be committed to lifelong learning, and our goal is to be able to provide care that is holistic, competent, and compassionate, while at the same time making sure that we uphold the highest professional and ethical standards and respect human dignity. So part of knowing about telemedicine is part of lifelong learning. So we have to know about telemedicine. And our goal here is to improve the quality of care that is rendered to our patients. And of course, at the end of the day, we have to make sure that one of our goals is to improve access to care by most of the Filipinos, if not all of the Filipinos. And we must contribute to it by, as we said, by giving patients access to equitable healthcare. And this is probably one of the biggest advantages that telemedicine can offer. So again, should we know about telemedicine? The answer there is a resounding yes. But let's now go back to our case. So this patient, we're not sure, is it UTI? Is it a prostate problem? So they're requesting you to see a patient via teleconsult. If you actually answer this patient via the phone consultation, via voice or text, this is actually a form already of teleconsultation. But for our purposes, we'll talk about here probably a video consult via technology. So the question here is, must you see this patient via teleconsult? So what is your answer? Yes or no? All right, so I've given you a few seconds to think. So the answer to this question is no. So if you cannot, going back to the section 1 of the PMA Code of Ethics, if you don't think that you can provide competent medical care in accordance with what we mentioned earlier via telemedicine, then we must not employ a teleconsult. Because remember, our goal here is to provide competent medical care. And when we talk about competence, what does that mean? It means the ability to perform a specific task in a manner that makes sure that the outcomes are desirable. And we have to have the ability to apply knowledge, skills, and abilities to new situations as well as to familiar tasks for which prescribed standard exists. So as we mentioned here, we're basically transferring our outpatient consultation, which is something familiar to us, into a new situation, which we do via technology. Now, if we do not have the ability to apply knowledge, skills, and abilities here, then we do not have the competence to do so, because that task should help us yield a desirable outcome, which means come up with a diagnosis and hopefully give the patient the appropriate treatment. So competence has to be developed before we involve ourselves in telemedicine. And this is a nice description in terms of what are the determinants of healthcare providers' performance according to specific standards. There are social factors, that means there are expectations from us by the community, our peers, as well as our patients. And there are social values, that the doctor is someone who is there to be able to provide healthcare at all times to patients. And then we talk here also about organizational factors, which means we talk about now what are available. And this will be where we may have some challenges because we don't have any training yet, supervision, what will be the mechanisms by which we do these tasks, and what will be clarity in terms of responsibilities and goals here. And then, of course, when we practice, there is always a provider motivation. And what does that mean? We have expectations of ourselves and what we want to do in our practice. We talk about self-efficacy. There are individual goals as well as some readiness to change. So that will be important if we do decide to embark on telemedicine. And what will be the competencies? We've talked about your knowledge, skills, abilities, and of course, traits are important. These are our values and virtues that are inculcated in us. Now, the provider behavior will be how do we perform according to specific standards. There must be an assessment that we are able to do. However, this is a challenge in telemedicine. Can we do really a complete assessment? Can we give a correct diagnosis? And can we make appropriate referrals for counseling and treatment? And our goal here, of course, is to have positive results in terms of health outcome and patient satisfaction. So these things we have to look at if we do plan to embark on telemedicine or teleconsultation. So it's been mentioned here too that, remember, part of our rights as physicians will be we have the freedom to decide and choose whom we will serve, except in cases of emergencies. So telemedicine is something that we do not employ in terms of emergent cases. So we do have the freedom to decide whether we want to make use of telemedicine or not. So we are not mandated to see this patient because it is not an emergent case. And as we said, we can only attend to patients within the limits of our capabilities. If we do think we cannot attend to this patient and give the patient the best care possible, which is in line with beneficence and non-maleficence, then by all means, you can refuse to see this patient via teleconsult. Now, this is one of the challenges that we've mentioned in telemedicine, in that it can potentially infringe on the physician privacy due to a 24/7 virtual availability. I'm sure that happens sometimes when you provide your patients with your cell phone number. There may be a few patients who may actually disregard that it is outside your office hours. So this is one of the challenges of teleconsultations, which means patients have to be aware that there's a time limitation or wherein they can access the service and the physician himself or herself. That's why we need to inform the patient of this and inform them of what we call off-hours resources. That means if we are not contactable, like in my case, I only do teleconsults between 12 to 3, and I respond to queries only until 5 p.m. Anytime after that, and if there is something important or they feel that the patient needs medical attention, I give them either the number of the emergency room or I tell them to proceed to the nearest healthcare facility where they can actually receive a face-to-face consultation. So this is the part of our responsibilities too, in terms of informing our patients. Okay, let's now go to the next question. How will patients know that you're practicing telemedicine? Unless one, they call your clinic and talk to your secretary, and secretary tells you that you're doing telemedicine, which I've been doing for the past, as I said, 15 months, and I've not had any face-to-face consults. Can we advertise? Especially now, you see this on social media. Can we advertise our teleconsult service over social media? Is it part of the things that is considered ethical? So again, we look at our local guidelines, and the PMA Code of Ethics says that we can actually promote the practice of the medical profession because our patients will not know it unless we have information. However, what is allowed to be contained in terms of your internet postings, which will be only the name, your specialty, your office hours, and your hospital affiliation. So contact numbers also, of course, may be included so that they can actually consult you. So this is an example of how I can be consulted by my patient. I have a Facebook page. So remember that this is separate from my personal page. My personal page is not accessible by my patients. That is my personal account. Now, this is a professional page attached to my personal page, which patients can access. So it has here what my service is, and they can set appointments here. And if you look at the About portion, it mentions what my services are for this page, which means this is basically for general education. So I post here information as to whether my telecommunication services are open for the week, or if I'm going to be out for the week and I'm not accessible. I give here materials to give patients instructions, for example, on how to take pictures of their upper airway. So things that can be useful for general education and management and general information that will be helpful for patients, especially with disorders of the lungs or sleep. So it has to specify what its function is for. So if you notice, I did not put in anything like my personal successes, my accomplishments, my training, because this is not allowable in terms of our PMA code of ethics. So we cannot, there's an answer that yes, we can post, but no, we cannot promote our practice in the sense that it cannot be used for soliciting or recruiting patients. So the goal of that page is not to recruit patients per se, but to give information. If you have someone who is actively recruiting online for you, then that becomes something that is considered unethical. And it said here that we cannot post or publish personal superiority in terms of special certificates, diplomas, trainings, specific methods of treatment, as well as operative techniques, that this cannot be contained in terms of our online sites. All right. Now, do remember that whatever interactions that we make via social media is going to be potentially problematic. So it's been identified that there's at least just 4 degrees of separation between patients and any other individual, or any individual and any other person who is online. So that means if we post something about our patients online, so although the patient may be very far from us, through another physician who interacts with another patient, this information may be transmitted to that patient. So this is why it's important that when you talk about telehealth, especially when we make use of social media for our healthcare practices, we have to be mindful of what we post online. So that means we have to remember that our patients cannot be friends on our personal pages. What we post online generally stays online, and what we post, even if we delete it, may eventually be retrievable. So this information always has to be kept in place. And we have to remember always to be digital professionals, as we've mentioned earlier on in this lecture. So let's now go next. So we know that we can actually indicate our practice online. We can choose whether to practice telemedicine. Now, however, if we do choose to do so, does this actually establish a physician-patient relationship? And this will be one of the challenges. Does a phone or virtual consultation actually establish a relationship? So if you notice, the answer here is a tentative yes. That means, ideally, when you talk about telemedicine, it is useful in the management of chronic conditions, or basically follow-up after initial treatment where it has been proven to be safe and effective. So it's more ideal that the first consultation is actually a face-to-face consult. But we do understand the limitations, especially in this era of a pandemic, or even in the post-pandemic. So it can also be used to manage specific cases, and we'll try to focus on some of that later. But the ideal first consult will always be a face-to-face consult. Now, as we said, this can be useful for follow-up of your patients, even for patients who have been hospitalized. So these are the basic uses of telemedicine as been dictated by the Centers for Disease Control in the US. And that for COVID-19, it can be used actually to screen patients. And for patients who have urgent care but are low risk and their non-COVID conditions, we can identify the patients who may need actually more medical attention. So we usually see, when I see the patient online, if they have signs of distress, I can immediately send them to the hospital, no? Because I see this online. So it's not via voice, it's not via text, but via a video consult. It will allow patients, of course, as we said, access to primary care providers, and this can be used in conditions such as mental or behavioral health or chronic health conditions. So what I've used this also very frequently in the past was in terms of helping patients in terms of like smoking cessation. So it can be used for coaching and support for patients, and as well as counseling, including nutrition. Now, another use will be in terms of monitoring conditions that are already chronic in themselves. No? So, diabetics, they can send you their blood glucose measurements, blood pressure measurements, and other remote assessments. And we'll show you some of these devices later on that can be used. And of course, it is useful for patients who have difficulties in accessing care. And this is one of the things that we have to balance. Are we potentially placing these patients at harm when we do telemedicine? But without access to healthcare, are we not placing them in greater harm's way? So we will be balancing the patients who have difficulty in accessing care so that we are able to at least provide them some form of medical assistance. Now, as I said, it can be used for hospitalization, but these are patients already with established relationships with a physician. So this is another aspect. That's why we put this in gray. So in these particular cases, you have already established also a physician-patient relationship. Other things that we've done also will be, I make use of this in terms of being asked to join family meetings in terms of deciding for advanced care planning and counseling for patients when a life-threatening event or a medical crisis occurs. And of course, we've also mentioned this, that it's usually for the low risk, but it's really non-emergent condition. So for those, especially in the US, who live in, let's say, retirement homes or long-term care facilities, this can be used as well. Now, this is not a physician-patient relationship, but do remember that telemedicine is useful for training and education in terms of peer-to-peer professional consultations that can be available. So if there is no, let's say, pulmonologist, sleep specialist in an area, a primary care practitioner or a practitioner in that area may contact me, and with the consent of the patient, we may discuss potential cases, and this gives this patient access to specialist care. What we do want to emphasize is that it is always very important to establish informed consent. Our medico-legal friends will always tell us that there has to be a written consent, or at least in my case, I do a verbal recorded consent, that they consent to the actual consultation. And the consent generally contains how telemedicine works, how they schedule appointments, privacy concerns, and this is very important, that there's a possibility of technological failure. I'm sure you've all experienced somehow at one point in time disconnection. And we will talk about also confidentiality breaches. There must be protocols of contact during the visits, which we'll emphasize later on, especially for this patient of ours who presents with urethral discharge. And what are the prescribing policies and how do we coordinate care for the patient? Now, we do have to make sure that patients are aware and they understand that there are difficulties and uncertainties. Uncertainties have to be emphasized in terms of telemedicine. And we must be prepared to recommend direct patient-doctor contact when we believe it's in the patient's best interest. So we can actually establish a relationship with our patient via telemedicine, but we have to make sure we are able to recommend direct patient contact when it is needed, aside from providing them off-hours resources. And as we said, one of the things that we have to be aware of is that we are able to provide our patients information about how to use their telecommunication system, because this is the only way we have to make sure that we are able to communicate clearly with our patients via telemedicine. All right, so our next question is, this patient denies any sexual activity but has urethral discharge. So can I look through my patient's social media accounts for my history taking to see if he has probably been involved in some sexual activity as been posted online? So this is a question that was addressed to psychiatrists, that should psychiatrists Google their patients. However, they said it's bad practice because it bypasses the personal relationship with our patients. It erodes trust because we are actually doing this hidden or surreptitiously, and represents an invasion of privacy. So it is discouraged that even if your patient's accounts are available in terms of the public domain, for you to access this without the patient's knowledge or consent. However, this can be done, they say, for certain situations, like checking for conflicting or falsified information, uncovering dangerous lifestyle choices. Now, it may be also to make sure that there's no mistaken identity. For mental health, especially for those who post things about self-harm, it may be used for monitoring as well as safeguarding vulnerable patients online. However, it's been said that Googling should really be done when there's really no other option. The challenge is whether to not to ask for consent, because if they do not ask for consent, we cannot get that information. But again, trust is important. So in general, it is not advised for us to Google our patients. Okay, now this is another tricky part. Can we do an online genital examination? Can we ask our patient to show to us his genitalia online to press to see whether there's any particular discharge? Can we do this online? So basically, with a teleconsultation, we can do everything in the same way, but we have to make sure we do preparation. In this particular case, it's just like looking at a chart to prepare for a consultation, and we'll show you later on how this can be done. We do our history taking, which can be actually more extensive, and I can show you how this can be supplemented in a teleconsult. Now, a physical examination will be limited simply to inspection. We do not have here palpation, auscultation, or percussion. However, this can be taken. This advantage can be taken away if you tie up with a physician in the specific area or a healthcare worker in the area who can do the examination for you and relay the findings via technology. And if you can have remote monitoring devices. But Jenny, this is one of the basic limitations of teleconsult, which is our physical exam. Patients can be given prescriptions and payments can be done via technology. So the question is, will this now be, knowing that, can this now be identified as, is this equivalent to a face-to-face consultation? So the answer here is, of course, is no. Although it has a lot of advantages also, which we'll show you in the subsequent slides. The gold standard of consultation will still be a face-to-face consultation. And our goal here is that when we deliver telemedicine services, however, it must be consistent with in-person services. And the evidence, it must be supported rather by evidence-based information as to what we do online. So let's talk about benefits. We've talked about the risks that physical examination may be insufficient. And we talk about probably being able to do a physical examination, but there are benefits, and we'll mention also some of the risks that are associated with face-to-face consultation. So one is that we can provide the patient actually online material for patient education. So remember that our visits usually in the clinic are around 17 minutes, that maybe, or 30 minutes at the longest. So we cannot provide the patient complete information. And in the Philippines, they found that Filipinos spend as much as 4 hours on social media. So one of the advantages now of telemedicine is you can provide them actually information which they can access. For example, on my page, I post their information about sleep, but the information is something I've already vetted or reviewed. I look at who the provider is, what the funding comes from, what the quality of the information is, because I review the evidence, and I make sure it doesn't violate my patient's privacy. Once you've identified that, then you can post it online for your patients to make use of. So your care for the patient is extended beyond your clinic, and that you're able to give them more information and improve their health literacy. So we've talked about here something about monitoring. So we'll talk about here 2 types of telemedicine. Well, we talk about synchronous, and this is what we've been talking about, where you talk to your patient as if it were an actual consult via video. But it can also be asynchronous, where patients can email or send you materials beforehand or even after the consultation. And we now have devices which can do remote patient monitoring. We can have oximeters which connect via Bluetooth, and a lot of patients already have the cell phones which can monitor activity, as well as smart watches as well. So we can divide this into 2 parts. Either it's a store and forward. I'm sorry, there's an error here. Store and forward here. This is store and forward, and this is real time, or what we call our video conferencing. So what we call as asynchronous, these are images. It allows us to a more flexible part in terms of our time. The problem is we may not be able to give as much attention or pay immediate attention to things that are sent to us by our patients, but it is of low cost because they will not spend for this. As we said, the delay in response is there. However, high resolution images can be set, and it's better fit in terms of our workflow for the day. Now, for what we call the synchronous consultations, these are video conferencing. So it makes use of video. It's the closest to an actual consultation that we will have. However, this is time consuming. It may be more expensive because our patients may have to spend for their internet connectivity, no? So especially if they're using data. Now, it allows for more clinical and in-depth examination, and it's immediate in terms of responses. However, the images here are lower resolution depending on the bandwidth that is available, and of course, it interferes with the daily workflow. So let's go back. Can we perform a physical examination via telemedicine? As I've mentioned, it can be done via inspection. However, the others can also be done by an assistant, or this can be done via video and sent to you if the patient has low bandwidth in terms of connectivity. However, we have to make sure that the patient is identifiable to make sure we're really seeing the patient and the areas we are examining are very visible. And we have to remember that we have a responsibility, especially even if when we refer these patients to other professionals, we remain responsible for the care. Now, these are some of the things that should be ensured. But when you do an examination, there must be visual and auditory privacy. All patients in the room at both sites, whether at your site or the patient's site, should be identified. There must be adequate lighting, and there must be minimized interruption. Okay? Now, you have guides on how to do a physical examination that's provided by the UP Medical Informatics Unit in terms of their guide document that was released in April 29. We also have a document in Pulmo which we released in March 15, 2020 as to how to do an examination for the pulmonary system. However, the challenge here is we have to make sure that we maintain patient confidentiality, privacy, and data integrity because they can be compromised. So that means we have to make sure that our systems are up to date in terms of security measures. So would I ask my patient to show me his genitals online? I would not. So anything that would be potentially compromising for an individual, I would not do. So that means these are things we have to avoid doing because images can be hacked. And this will be a potential problem. So this tells you now part of the limitations really of telemedicine. So as we said, although we promise our full efforts at safeguarding confidentiality and privacy, it cannot be absolutely guaranteed. So we're now almost down to the last parts. Can we prescribe via telemedicine? Can we give medications? Well, it is allowed by the FDA rules on e-prescription, especially during the pandemic. And that we have to make sure, though, that it is at the advantage of being able to provide the patient, especially a typewritten, which in my case is a computerized form, which allows less, it has less room for misunderstanding. And you have to make sure here that's important is that the patients understood whatever advice is given to make sure that there is no misunderstanding, and you try to make sure that there is continuity care that's provided. The advantage of telemedicine is allows me to keep now a detailed record of whatever advice I give because it is done by technology and there is a recording in terms of the information that I send to the patient. And I can actually give them videos, for example, in my particular practice on how to use inhaler devices that they can look at. And it now makes sure that the patients use the medications properly. Okay, all down to the last, I think, 2 questions. Can we charge for telemedicine? Well, obviously, this is service rendered. Therefore, a fee can also be extracted. Just remember that the charging for telemedicine follows that of actual life, where the capacity of the patient to pay is the most important. Right? So we must be able to extend these services also to patients who may not be able to pay. And that's part of our goal as physicians, to be able to make sure that healthcare becomes equitable. Now, of course, you can charge depending on the difficulty of the case, maybe higher charges, standards of the community, stature, expertise, equipment and establishment of running costs, time involved, and cost of living. Obviously, here we don't have issues in terms of the locality when the practice is carried out. Right? So last question is, can telemedicine itself be unjust? So I think the answer here, of course, will be yes. Because, of course, patients who do not have access to technology and even older patients who are not aware of how to use it can be marginalized. So physicians must be aware that telemedicine technologies could be unaffordable to patients, and it can actually further widen the health outcomes gap between the poor and the rich. So part of our goal is to make sure that this tool becomes something that allows us to reach more patients and give them more access to our services as healthcare practitioners. So let me end with this. It's been said that from the Hastings Centers that telemedicine needs ethical guidelines. It is to help define what is the professional conduct in terms of our relationships, how do we maintain patient privacy and safety, and of course, to make sure that the human values of relationships are maintained despite this being done over technology. We have to involve our patients and protect their autonomy, and at the end of the day, we have to weigh the benefits and know the harms that can be brought about by the use of teleconsultation. Right? So going back to our patient, Teleconsults are a new tool that gives our patients wider access to healthcare and allows us to reach more patients. But in the process, we have to understand our patients' autonomy, where informed consent is necessary for them to be able to participate. And we have to have the responsibility of knowing and developing our skills before we embark on participating in teleconsults. It must be done for the benefit of our patients and hopefully the Filipino population, and we have to do our best to avoid any form of harm that may occur. And at the end of the day, this has to be a service that is just and that offers healthcare to every Filipino in our nation. So with that, I'd like to thank everyone for your kind attention, and I do hope you picked up something new for this morning. So again, my thanks to the Philippine Urological Association Mindanao chapter, and to everyone for their kind attention.
Our next speaker is the current Hospital Director of Urology Center of the Philippines and Chairman of the Department of Urology, East Avenue Medical Center. He is the current Secretary of the Philippine Board of Urology, Vice President of Philippine Alliance for Urolithiasis and Philippine Society of Uro-Oncologists. He was the past President of the Philippine Urological Association, past Council Member of the Urological Association of Asia, past Board of Governors of the Philippine College of Surgeons. Dr. Lantin earned his degree in medicine and master's in hospital administration at the University of Santo Tomas. He finished his residency training in urology at the East Avenue Medical Center. He went for further training in robotics at NARUS, North American Robotic Urologic Symposium, master's course on robotic urologic oncology at Intuitive Surgical Lab, Sunnyvale, California, USA. He also had training on brachytherapy for prostate cancer at Chicago Prostate Cancer Center, USA, on green light laser for prostate in Bangkok, Thailand, and on quanta thulium laser for prostate at San Donato University Hospital, Milan, Italy. He also completed training on urolithiasis and endourology at First Affiliated Hospital, Guangzhou Medical University in China under the tutelage of Professor Guangho Zheng and fellowship in minimally access surgery at World Laparoscopy Hospital in New Delhi, India. Let us now welcome our next speaker, Dr. Pedro L. Lantin III.
Good day, everyone. First of all, I would like to congratulate the PUA Mindanao chapter and its members, headed by Dr. Rod Hipol, for organizing this annual event. I would also like to thank the organizing committee, headed by its course director, Dr. Nimrod Firasa, to talk about Urology Center of the Philippines, my recollection, my thoughts, 1995 up to 2021, 26 years of delivering world-class urologic care. Early 1995, an idea to establish an ESWL center by then PUA President Benji Reyes was organized. We were in Las Vegas in our hotel room at the Circus near the American Urological Association Convention Hall when he invited me to join as one of the founding directors. I had some doubts about forming one because we were still residents at that time and might get the displeasure of a more senior urologist. After convincing me, we then invited other PUA members to join in, by the likes of Dr. Herman Sorongon, Dr. Noel Hipolito, Dr. Clayton Blas, and the likes. At that time, only PLI at St. Luke's Medical Center and Manila Doctors Hospital had an ESWL machine, but fortunately for us, Manila Doctor Hospital was about to fold up and eventually closed later that year. That started the ball rolling, as to speak. And recruitment of doctors, a combination of senior talented and well-known urologists in multi-institutional affiliations were underway. Dr. Ponce Bernardo from East Avenue, St. Luke's, Dr. Eduardo Gatchalian, PGH, Manila Doctors, Dr. Tony Anastasio, UE, St. Luke's Medical Center, Dr. Patron, National Kidney, JR, and AFP, Dr. Mendoza, Cardinal Santos and East Avenue and NKTI, and Joey David from Veterans and St. Luke's, and Dr. Dan Mariano from JR. The fact I and Benji was on our senior year in training when the company was being formed, and us being in the board of directors, was kept a secret to prevent getting the ire of other urologists who were not members of the company. Many meetings soon followed, and in October 1995, the name Urology Center of the Philippines Incorporated came up. At the time, we just wanted to use UCPI as an acronym and make it as a low-profile company because we were hesitant to be criticized for using the name Urology Center by other senior urologists. And yet the center only has an ESWL machine to boast of. On December 20, 1995, SEC registration was granted, and this cemented the company to the healthcare industry. On April 1996, the first venture of the company, the Stone Unit at Manila Doctors Hospital, was established, and Dr. Eduardo Gatchalian being the top honcho that took care of the everyday operations. Soon, the UCPI Stone Unit at Manila Doctors Hospital had shown an increase in census and revenues. This prompted the board in 1998 to venture into a freestanding ESWL clinic in Quezon City called the UCPI Ambulatory Care Center, headed by Dr. Tony Anastasio. By this time, we have established 2 ESWL centers strategically located, one in Manila and the other in Quezon City, which will actually serve almost all our members. We slowly expanded our services into a full-service hospital in Quezon City. And in 2006, we changed our name from UCPI Ambulatory Care Center to Urology Center of the Philippines in preparation to building a hospital. In 2011 November, the Urology Center of the Philippines Hospital was born and granted license to operate as a Level 1 specialty hospital by the Department of Health, making it the only private center or private specialty center in urology in the country. Our dream that UCPI to be internationally recognized was attained on September 2017 as UCPI was recognized by the International Alliance of Urolithiasis, headed by the most famous Professor Zheng from Guangzhou, China, as one of the training centers in endourology. Thanks a lot to Dr. Abet Aquino. And in 2018, the company acquired a 1,000 square meter lot just adjacent to the hospital and built a 3-story parking lot. This was in preparation for the future expansion of a 7-story UCPI hospital. And in March 2020, the coronavirus pandemic forced Metro Manila to lock down. This prompted UCPI for the first time since its opening to close its operations for 2 weeks to prepare for the unknown. I would like to present to you the present Board of Directors. The composition of the present Board of Directors includes mostly past presidents of the Philippine Urological Association, former chairman of the Philippine Board of Urology, and former and present heads of the recognized training institutions in urology. In short, there are the who's who in Philippine urology. I would like to present to you the mission of the hospital. It notes that we are an institution dedicated to provide affordable and high-quality urologic care, advanced training, and relevant research in urology, thus contributing significant to improve healthcare in response to global challenges. The vision of the hospital is to be the best urology center in the Philippines, an internationally recognized leader in urology. I would like to share to you, in my mind, the secret ingredient why UCPI is the #1 center in urology in the Philippines. Please take note of the following. Secret ingredient #1 is to make your institution the best in your specialty. Second, make it a Euro patient-friendly hospital. Third, prepare and learn the in and outs of the operation. Fourth, take good care of your finances. Fifth, take good care of your employees. And lastly, you have to pray and thank God Almighty. For secret ingredient #1, make your institution the best in your specialty. You have at least to do a benchmarking both locally and abroad to know what the others have in terms of protocols, prices, equipments, and the likes. Get the latest toys available in the urological field and make sure to have personnel available to teach, assist urologists that would use them. Recently, we have purchased an Artemis machine. It's an MRI fusion biopsy machine. We have the thulium laser for the prostate. We have the holmium laser for stones and the treatment of strictures. We have the brachytherapy for prostate cancer, low-dose radiation. We have the transurethral microwave therapy of benign prostate enlargement and prostatitis. We have the erectile dysfunction shockwave treatment therapy. We have 3 ESWL machines. We have recently acquired a urodynamic machine, and of course, we have an ultrasound machine dedicated for OR use. As much as possible, you have to have a complete array of urological equipments. We have a flexible ureteroscope with 2 rigid ureteroscopes on hand. We have a wide array of different sizes of nephroscopes for the standard, mini, and super mini PCNL. We have 2 C-arms available for OR for simultaneous PCNL cases. We have the latest ultrasonic and pneumatic lithotripter from Boston Scientific, Storz Calcuson, and 1 lithoclast. We have, of course, laser resectoscopes and a laparoscopic machine. The center also has an available ancillary units to support hospital operations. We have radiology, who boasts of 4 top-of-the-line world-class ultrasound machines. We have a CT scan dedicated for urological procedures, and of course, a new X-ray equipment. We also have a 4-bed hemodialysis unit. We have a complete laboratory facility used for most common urological problems. Of course, you should need a pharmacy, where the drugs will be available, that are used in daily urologic practice. Make your institution known by hosting workshops and conferences, both local and internationally. So as you can see, these are some of the international and local workshops. No? You could see famous doctors like Jen Strasweiler, Ali Gosen, no? Visiting the center. Okay. Secret ingredient number 2. Make your facility a Euro patient-friendly hospital. For urology-friendly hospital, you have to make sure that your doctors feel comfortable. You have to have a lounge for doctors where they could stay while waiting for their cases. Make sure that the urologist receives regularly monthly PhilHealth and professional fee reimbursements from the hospital. There should be an easy access of scheduling of patients and approvals of HMOs. And for new graduates and new practicing urologists, the center will facilitate their HMO accreditation. As a result of these Euro-friendly strategies, we have around 40 to 50 urologists now practicing monthly in the hospital. For patient-friendly hospital, for making this a patient-friendly hospital, make sure that the hospital premises are clean. You have to have safety protocols known to the patient. There should be an ease of admission and discharge. In fact, in our center, a patient after the procedures would be accompanied by a staff until he or she enters his vehicle. And recently, in addition to being the center, to this being a patient-friendly center, we have hired a dedicated staff that handles concerns and feedbacks from the patients. Secret ingredient number 3. You have to prepare and learn. Top people in the corporation should be qualified in their positions. Make sure that they have a master's degree on the field of interest. They should learn from people experts in their fields. They have to talk to people, no, and ask them their experiences in running a hospital. Should craft policies that is well structured, consistent, safe, and aligned with existing policies of the Department of Health, PhilHealth, Philippine College of Surgeons, and the Philippine Urological Association. I would like to share to you how we prepared for the COVID pandemic. No, we placed a remote treatment option for ESWL, in which the doctor is outside the treatment area and is monitored by video and monitoring the procedure by video. We have a separate pathway for healthcare workers and patients. We have created protocols, no, for OR. As you can see, we usually change this every 2 weeks depending on the situation at hand. We also place a decontamination tent in the operating room, no, and for donning and doffing techniques are in place. Lastly, we have to learn from our past experiences. So we have, as far as I can remember, 2 sour investments. The first sour investment that I can remember was having a Eurovan. it was a good idea in which we could serve, no, provinces in Luzon without ESWL machines. No, but the problem is we have to treat cases as far as Bicol, and then the van would go as far as Ilocos. So it was not a good idea after all. The Eurovan was closed due to financial losses. And one thing learned here is do not invest in something in which you cannot directly help with. Second is the placement of an ESWL machine at Lucena, in which after a few months, it closed because of poor census. But then there's a quote, failure is not the opposite of success. It's part of success. Secret ingredient number 4, take good care of your finances. Many might not agree, but my advice is to expand within your means. Use money which you earned for the expansion. Don't take out loans from the bank, so there will be no pressure in making both ends meet. Second, check on the purchases of supplies and equipments. Get the best deals. Do bidding. Try not to overstock on supplies. Go to joint ventures and X deals with regards to your equipments. Hire employees that can do multitasking capabilities. From this, you can save, no, in hiring extra unnecessary employees. Treat company as if this was your own home to save on electricity and water. If you see, lights open without any people, I personally make rounds and close the light or the air conditioning if there's no people. So these little things, in the long run will save a lot, in the finances. And lastly, I would check on the cash flow every day before I leave the hospital, just to see how much money came in and how much money came out. What is fun is that I have no signing privileges in the corporation. But what I do is check every checks that is being disbursed, and every income that is seen by the hospital every day. That is before I leave the hospital. The formula used to make this corporation successful was to entice more urologists to practice at the center. So what we did was hold seminars, workshops, and advertise the center. If they see the capabilities of the center, they will bring in their patients. Our assumptions were right. Only one patient per urologist per month, that would bring patients here. For example, 50 urologists times one patient, there's 50 patients right away. So this formula helped us grow. Secret ingredient number 5, take good care of your employees. Remember, the greatest asset of the corporation is the human resource. Invest in your employees. Finance and support all learning activities for them to grow. Give them leeway to make decisions for them to build confidence on their own, and just guide them to the path of what is right. Make sure that they get their salaries on time, for they need it. I remember when we were just starting and there was no money laying around, the top priority of the corporation was to make sure that the employees get their salary on time. I would like to share to you a quote from J.W. Marriott, an entrepreneur of the Marriott Hotels, and it states, "Take good care of your employees, and they take good care of your customers, and the customers will come back." I think this philosophy has been working for our company. Secret ingredient number 6. Don't forget to pray and thank God the Almighty. We have organized First Friday Masses. We have placed a 3 o'clock prayer habit, Angelus, and of course, we crafted a UCPI prayer early on 1997. By being close to God, everything will fall into places. Trust, honesty, and transparency between the board of directors, between the staff's members, will be easy to find. And lastly, for my take-home message, I would like to share to you Jack Ma's 10 rules. First, learn from the mistake of others. Focus on quality, not the size. Be the first. Prepare for the future. Respect your competitors. See challenges as opportunities. Believe that you can make it. Surround yourself with greatness. And the last 2 is live healthy and have fun. In that, I would like to close my lecture. And again, thank you so much for the organizing committee of the Philippine Urological Association Mindanao chapter for inviting me. Thank you so much.
speaker graduated from the University of the Philippines College of Medicine and finished his urology residency at the UPPGH, after which he completed 1 year of fellowship in minimally invasive urology at the University of California,
Irvine,
under the mentorship of pioneering endourologist Dr. Ralph Clayman. To date, he has published several works in the field of endourology and urotechnology in international peer-reviewed journals and currently serves as an expert reviewer for the Journal of Endourology. He is a diplomate of the Philippine Board of Urology, consultant urologist and assistant professor at the De La Salle University Medical Center, and active consultant at Medical Center Manila. Let us now welcome our next speaker, Dr. Rafael Benjamin B. Arada.
Hi, good afternoon, everyone. I'm Dr. Rafi Arada, and I'll be presenting on the topic of the latest technology in urology. First off, I would like to thank the PUA Mindanao chapter led by its president, Dr. Hipol, the rest of the officers of the distinguished organization, and to Dr. Firaza, the course director, for this very, very kind invitation. It is such an honor to be invited to speak to a group of highly distinguished urologists. And I am also glad to see that there are also many interested non-urologists who registered for this event. So welcome to you all. For my disclosures, I have no financial relationship with industry, and this presentation is not sponsored. However, I think it's pertinent to note that certain research works and trials on some devices which I will be presenting, wherein I was a co-investigator, have been sponsored or supported by their respective manufacturers. To begin, as urology is a specialty that deals with a very diverse patient population and treats a wide variety of disease conditions using different modalities, advancements in technology will always have an impact in the improvement of our field, to the point where some would actually argue that urology is increasingly becoming a technology-driven specialty. And as such, for the next half hour or so, I would be focusing my discussion on certain technology that are currently changing our field or would eventually significantly have a major impact on the way we do things. In the past century, the world has witnessed an exponential growth in technological advancements. And just in the past few decades, scientific breakthroughs and innovations are rapidly advancing at such pace that it's getting more and more difficult to keep up already. And one of the best examples to demonstrate this in the field of urology and in minimally invasive surgery is the development and use of surgical robots. Intuitive Surgical launched the Da Vinci S surgical robot in the market just 15 years ago in 2006, back then allowing surgeons, especially us urologists, to perform minimally invasive surgery with improved dexterity and surgical precision under 3D high-definition vision. And this model actually emerged as a simplified setup of the first generation prototype they released in 1999. And then just every few couple of years or so after that, we saw significant improvements in each of the subsequent models. In 2009, the SI was released with more advanced features, allowing dual console surgery, Tile Pro integration, and all that. And eventually, further advancements in vision and instrumentation. The SI model would then become so popular and widespread and used in a lot of centers worldwide, including hospitals here in the country that have adopted the use of robot-assisted surgery. And what's in the picture is actually the SIE, which is like the economic lower-cost version of the SI, wherein instead of having 4 arms, it only has 3, but it's still an SI. Then in 2014, even more advanced, the XI was released in the market. While the surgeon console for this model looks pretty much similar to the SI, the big change is really in the patient cart design, which they totally reinvented from the previous model. First, it allows for an automated setup mechanism, which allows for easier and more optimal docking. Also, it has an overhead instrument arm architecture that would allow anatomic access from practically any position, and with longer instrument shafts, smaller and thinner arms, and redesigned joints. And although also with 4 separate arms, the camera or the endoscope can be attached to any of the 4 arms, unlike the SI, which has 1 arm dedicated for the camera. And not to mention its camera, which was also upgraded to be a more compact and has improved clarity and visual definition. And these, together with other upgrades, allowed easier and optimal setup and now allows multi-quadrant operations with maximum mobility and flexibility of the system during surgery, under better vision and with more advanced instrumentation, opening up the possibilities of a wider range of surgical applications. And as advanced as the XI was, in 2018, an even newer model was released, the SP or the single port model, with a single robotic arm incorporated with smaller wristed instruments and an articulating camera, allowing entry and procedures done through only a single port. With all these advancements in surgical robots, urology is one of the disciplines that has greatly benefited the most from this technology, with a very wide range of applications to our field, in pelvic operations such as radical prostatectomy and radical cystectomy, as well as renal procedures such as radical and partial nephrectomy, and also in reconstructive surgery such as pyeloplasty. Now, while Intuitive Surgical's Da Vinci has dominated or basically monopolized the market for surgical robots for the past 20 years, in 2019, a lot of their core patents for the technology have actually expired already, and this then allowed many possible competitors to enter the field. And among the new surgical robots developed recently is the Revo-I from Korea, which, as you can see in the picture, is very, very similar in design to the Da Vinci, with the 4-arm patient cart, a surgeon console, and the vision cart. But it comes at a much more affordable price, with good outcomes also shown in the recent human trials. CMR from the UK has also released their surgical system in 2019 with independent individual modular robotic arms mounted in portable carts. It comes with a lot of exciting features, among which is the ability for haptic feedback, and early data for its use are also likewise promising. Companies from Germany and Japan are also in the game, coming up with their robots that have already started to obtain approval and have likewise been shown to have good outcomes in early human trials. And a lot more of other companies from different countries all around the world are now on this robotic surgery race. And with these developments, it is expected that the use of robotics in the field of urology will definitely be more widespread in the next coming years or so. However, again, at present, despite its demonstrated benefits, the most important concern for adapting the use of surgical robots in urological surgery, probably more than any other available technology, is the cost, with the SI or the XI costing around at least $2 million, with additional expenses for maintenance and disposable equipment. And although the newer models promise greater affordability and accessibility, none would in the near future probably be down to costs that would approach simple laparoscopic surgery. And other issues being raised are with regards to training, specifically if current robotic surgery credentialing policies are adequate to ensure surgeon proficiency. And as still this is a relatively still new technology, there are still some arguments about safety concerns, although of course data over the past decade have demonstrated good patient safety outcomes already. But regardless of these concerns, it is already probably safe to say at this point that robotic surgery is here to stay and will definitely play a major part in the future of urologic surgery. Now, aside from robotic surgery, endourology is probably the field that deserves a more in-depth discussion when it comes to the topic of urotechnology. In fact, endourology is so closely linked to advancements in technology that what we used to know as the WCE, or the World Congress of Endourology, is now called the WCET, or the World Congress of Endourology and Urotechnology. And probably it is in the area of endoscopy and lithotripsy that has really been making the most of the technological advancements in the recent decade, as this field deals with a lot of new advancements in optics, high energy devices, minimally invasive access, and imaging modalities, among others. There are a lot of potential technological innovations that we can explore and utilize. Flexible ureteroscopes have been around for quite some time, and was actually all the way back in the 1980s when improvements in the scope into how we know it now were introduced, such as having a working channel within the scope, and as well as allowing a mechanism for active deflection. And these have been standard features of the scope since then. And over the years, there have been some improvements in durability, miniaturization, deflection capability, and replacing fiber optics with digital imaging, eventually lowering the costs and expanding availability. But still, flexible ureteroscopy does have its limitations, as standard scopes can only typically be up to a certain diameter to be allowed safe entry into a narrow ureter or an access sheath. And with just a single working channel, limiting the simultaneous use of instruments and limiting irrigant flow capabilities. And of course, there are still limitations regarding its durability and cost, especially when we compare these to the rigid ureteroscopes. However, recent improvements in optics and materials are allowing flexible ureteroscopes to be cheaper, and taking advantage of the advent of single-use disposable scopes allows for rapid prototyping of newer novel endoscopes. One example is the development of shorter length ureteroscopes. Standard flexible scopes are typically around 65 centimeters long, and by physics, the length combined by its narrow diameter would result in relatively low irrigant flow rates, especially when instruments are inserted through the same single working channel where the fluid passes through. And of course, irrigation is very important to us in terms of visibility and surgical efficiency. Now that manufacturers are no longer confined to the one-size-fits-all approach to developing these scopes, recently, as an example, Dornier developed a prototype for a shorter ureteroscope, which is female-specific. So it takes into account the shorter urethra in females, and the scope just has a working length of just 45 centimeters. So the premise of this is that it would not only require less material to produce, but could actually increase the irrigant flow rates during ureteroscopy. And we actually did a benchtop study on this, which we recently published in the Journal of Urology. So here we found that although the 45 centimeter scope is the same in all aspects, except for the length to the standard scope, we demonstrated that there was actually a significantly higher flow rate by an average of 11% more, with the highest increase noted when there's an end-gauge basket in the single working channel. And there were also noted no differences in deflection capabilities. And from this prototype, it's exciting to see how these differences would eventually translate to clinical utility. But really, even with modifications like this, the increase in flow rates would still be limited, considering the fact that the same single channel we use for irrigation is also the same channel where we put instruments such as baskets, wires, and laser fibers. And also, having just a single channel in the scope makes flexible ureteroscopy using multiple instruments a bit less efficient when we have to remove one instrument, like a laser fiber, all the way through the length of the scope before we can insert another one, such as, say, a basket for stone extraction. And of course, the best way to go about this limitation is to figure out a way to put another channel into the scope itself. And that's exactly what Wolf did. So this is the Wolf Cobra. It is a flexible fiber optic ureteroscope which has two separate channels or lumens within it. So the first channel or lumen is designed as a traditional working channel. And there's a second channel which allows for simultaneous instrumentation or can be attached to a suction or even for just additional flow of irrigation fluid. And having two separate functional channels could allow for applications such as simultaneously using a basket to secure a stone on one channel, with the laser fiber on the other channel simultaneously performing laser lithotripsy. This can also be applied, for example, resecting an upper tract tumor, with an instrument on one channel maintaining traction on the mass, while the laser fiber on the other lumen performs the resection. Or we could have the second channel used exclusively for irrigation, which would provide increased flow and improved visibility during ureteroscopy. Now, earlier studies by the team of Dr. Monga way back in 2011 demonstrated that deflection and flow characteristics were superior when larger or multiple simultaneous instruments are used in the working channel of the dual lumen scope. Now, as far as its clinical implication, our team at UCI actually had the wonderful opportunity of performing a prospective randomized study to objectively assess the efficacy, safety, and ease of operation of a dual lumen scope compared to the traditional single lumen scope. The study is still ongoing currently, but preliminary results from our first 79 patients undergoing ureteroscopy for renal stones less than 2 centimeters revealed higher absolute stone-free rates with using the dual channel scope. And overall, the operative times were similar, but in cases requiring laser lithotripsy, the lacing time was significantly shorter, actually less than half, with using the dual lumen scope. And among the patients with pre- and post-operative CT, the median rate of stone clearance was 7.1 cubic millimeters per minute for the dual lumen group compared to just 3.7 for the single channel. Our preliminary results also revealed actually that the dual lumen scope is subjectively better for surgeons in terms of visibility, comfort, ease of deflection, and overall ease of use compared to the single lumen ureteroscope. Soon we will be able to publish our findings once the trial is completed, but for now these definitely look like very promising results. But still, again, despite current and foreseeable future advancement in the scopes, its diameter will always be a major limiting factor, as ureteroscopes can only typically be up to a certain diameter to be allowed safe entry into a narrow ureter or ureteral access sheath. And as ureteral injury is a feared but quite frequent complication of access sheath insertion, as we would all know, surgeons would typically not go beyond the French 12 or 14 size sheath for uteroscopy, as larger sizes would have a potentially higher chance of causing injury to the ureter. And with that in mind, the team of Dr. Clayman at the Department of Urology partnered with researchers from the Department of Engineering to develop a device that could accurately measure the amount of force exerted by deployment of the access sheath as it goes all the way up the lumen of the ureter. This is the UC Irvine ureteral force sensor device. It is a prototype model, but is actually already being used clinically in the operating room and endoscopy suites. And it is a small handheld device. And how it works is that it has a force gauge at the tip, which attaches to the proximal end of the ureteral access sheath during deployment, with a guide wire passing through it, as shown in the photo. And then the device is then connected wirelessly via Bluetooth to a tablet, with an app showing in real time the amount of force being exerted by the sheath on the ureter. And based on initial porcine studies on the device, a threshold of 6 newtons was determined to be the safe threshold to avoid causing injury to the ureter. This force sensor would then allow the urologist to use a larger ureteral access sheath, knowing with confidence that it would still well be within safe limits and avoid causing injury to the ureter. This likewise makes it easier to pass the scope multiple times back and forth to remove more fragments of kidney stones in less time. And with this, we can go as high as, say, a French 16 outer sheath, or possibly even bigger than that. And if the sensor detects the force to be approaching 6 newtons, the safety threshold, then we can just stop and then shift to the next smaller caliber sheath until we can eventually use the largest possible sheath that would still be well within the safety limit. And in the first clinical trial on 200 patients at UCI, which was published recently at the Journal of Urology, a French 16 sheath was able to be deployed in 61% of the renal units with a mean peak force of 5.7 newtons. And although 2 high-grade ureteral injuries occurred, it is important to note that in both cases, more than 6 newtons of force was recorded at some point during insertion. And it was also noted that the severity of the ureteral injury, as determined by the pulse or post-ureteroscopic lesion scale grade, correlated directly with the peak insertion force. And now, with the possibility of deployment of larger access sheaths and the previously discussed advancements in flexible ureteroscope, comes the improvement and safety and efficiency of ureteroscopy and laser lithotripsy. But of course, the third and most important component to take into consideration for efficient laser lithotripsy is the lithotriptor itself. Since the 1990s, when Dr. Denseth first performed laser lithotripsy for urolithiasis, holmium-YAG laser has pretty much been the gold standard modality for laser lithotripsy. And for the past 30 years, holmium-YAG has been the ideal laser for us urologists due to its good water absorption, its proven safety and effectiveness in fragmenting any type of stone, and also having the ability to be used for soft tissue applications with very good hemostatic characteristics. And since then, there have likewise been some improvements in the technology through the years, with modifications in settings such as in pulse width and duration. And one of the notable recent innovations in holmium lithotripsy is the MOSES technology, wherein the laser settings are modulated so that for every pulse, there are actually two successive pulses fired very rapidly one after the other. The first one parting the water like Moses, and the second pulse going straight right through its paths, hitting the stone directly. And with this, they demonstrated benefits included reduced retropulsion, as well as more efficient stone ablation and shorter fragmentation times. But still, all of this is built around holmium-YAG laser lithotripsy technology, which by its design would still have its limitations. And now, the technology that is really making waves in the endourology world recently is a thulium fiber laser, and thus would probably require a more in-depth discussion. Thulium fiber laser, introduced fairly recently, is a totally new and exciting technology. For those who may not yet be familiar with this, before we discuss how it works and what it is, let's settle what it is not. So thulium fiber laser is not the same as thulium laser or thulium-YAG laser that we all know. As urologists, we are familiar with thulium as the one we use for prostate enucleation and all that. But thulium fiber laser is a totally different technology. To fully understand and appreciate what's new and exciting about thulium fiber, let's compare it to how our typical holmium-YAG lasers work. So these next series of simplified images are from a paper by Dr. Taxer, who has done really tremendous work on this topic. So traditionally, this is how our lasers work. Within a cavity, you have a YAG crystal embedded with holmium ions, and then light emitted from a lamp inside interacts with the ions, resulting in the emission of photons, and then radiation is reflected between the mirrors within the cavity, being amplified as they interact with the excited ions and stimulate emission of multiple additional photons. And then, a transient opening of the cavity releases the radiation in the form of a pulsed laser beam, which is then transmitted to a laser fiber or the patient fiber by means of a complex optical laser beam coupling system. And as a single cavity can typically go up to only as much as 30 watts, we would need several resonance chambers to achieve higher power and frequency levels. And by doing so, they generate much more heat, which would require big water cooling systems. And that's the reason why holmium laser machines are so big. Now, thulium fiber laser, on the other hand, works in a totally different way. Instead of having a laser cavity wherein radiation is generated and amplified from a lamp-pumped solid-state laser, thulium fiber laser, as the name implies, consists of very thin and long silica fiber which has been chemically doped with thulium ions, which are then excited by multiple laser diodes. So instead of having a cavity wherein the energy is amplified, the fiber itself is the amplifying medium. And then instead of having a complex optical system to transmit this to the patient fiber that goes into the ureteroscope, we can directly attach the patient fiber to the thulium fiber laser. And compared to the other system, this one is relatively simple and does not generate much heat, and would therefore not require large cooling systems to perform at higher power levels. And currently, thulium fiber laser is being used with significant advantages in lithotripsy, both for fragmentation and dusting settings. And also, it has soft tissue applications, such as in prostate enucleation and resection of urothelial tumors. Now, making a comparison between thulium fiber laser and holmium-YAG, I will just touch on a few of the notable advantages, as discussing the full capabilities and specifications of thulium fiber laser would probably need a whole lecture by itself. So to compare with holmium YAG, first they allow for much thinner fibers than the ones we have for holmium, with core diameters as small as 50 microns, and with speeds that can go up to more than 2000 hertz, coupled with pulse energies that could go as low as 0.025 joules, and the ability for much higher pulse durations. This allows us to play with a wider range of settings, such as combining very low pulse energies with very high frequencies to achieve a certain level of power. And with this, it has been demonstrated that thulium fiber allows for a much faster stone ablation for either dusting or fragmenting for any stone type. And while both holmium and thulium fiber laser systems are capable of dusting stones, thulium fiber produces more quantity and better quality of the dust, meaning much smaller dust particles after lithotripsy, which could then be more easily evacuated. And lastly, thulium fiber produces significantly less or sometimes even non-existent retropulsion, which means it could be easier for surgeons, especially the trainees, to perform lithotripsy with these. And of course, as we previously mentioned, without the need for large water-based cooling systems, the machines for thulium fiber are reasonably small and can run on just simple air cooling mechanisms with a fan, and in turn makes them small enough to fit in your typical endoscopy cart, or for those who would prefer to take their machines with them to different hospitals or what have you. It can possibly be possible with this. And also, the machines are simple enough to be plugged in a standard power outlet without the need for any complicated electrical wiring, like anyone who tried to install a holmium laser in their center would be very well familiar with. And now as to the current state of thulium fiber laser machines currently available in the market and in clinical use. IPG Photonics was the first to gain approval for the clinical use of this, but it was first approved only in Russia and in India back then. And as such, they have gotten quite a head start with this technology and were able to produce the first clinical data for it. The other is the Olympus Soltive Super Pulse. Initially, until last year, in the US, this was just being used in the context of clinical trials in a few centers, with Ohio State being the first. But now, recently, it has gotten FDA approval already for clinical use. And so now, thulium fiber laser technology is making its way into more and more centers in the United States. And of course, soon, hopefully, the rest of the world. Now, as we have discussed the latest technological advancements in access, ureteroscopy, and laser lithotripsy, we now move towards finding the optimal technique for safe and efficient ureteroscopic laser lithotripsy. Putting it all together, we performed a study to demonstrate the optimal renal stone dusting technique, combining the dual lumen scope, the ureteral access sheath, and the thulium fiber laser, which we presented at the recent meeting of the AUA Western section last year. In an ex vivo study of 48 porcine kidney ureter models, divided into 8 groups according to laser type, the use of a dual lumen scope with suction, and the use of an access sheath, calcium oxalate stones were implanted into the kidneys and dusted with 8 different combinations of laser, scope, and the use of an access sheath. And then dusting was done at 16 watts for 20 minutes, and then the residual fragments were then assessed. Here we found that the greatest stone clearance of 94% was achieved with using the thulium fiber laser through a dual lumen scope with suction and using a ureteral access sheath. And the lowest stone clearance of 65% was achieved with a holmium laser through a single lumen scope and no ureteral access sheath use. Very interestingly, when used without either a suction or access sheath, there were no differences in stone clearance between thulium and holmium lasers. And thulium fiber had a greater stone clearance than holmium YAG when suction was applied in the absence of an access sheath. So with this, it was demonstrated that in terms of renal stone clearance with dusting, The advantages of thulium fiber over holmium were manifested when it was used in conjunction with a means of evacuating the stone fragments, such as concurrent suction to a dual-lumen scope and or a ureteral access sheath. Now, considering all these benefits of the thulium fiber laser, we now get to ask, is it the future and should it eventually replace the holmium YAG as the standard for laser lithotripsy? Now, with the data available, most probably that's where we're headed. But then again, this is still a fairly new technology, and although already approved with good clinical safety and efficacy results, large clinical trials are still currently ongoing for us to fully realize its capability and long-term safety profile. For example, things such as how about the heat generated by the energy on the kidney? While it's known to be generally safe, it's still interesting to study, and we actually did and published a recent study on this, where in an in vivo study, we noted that in the absence of a ureteral access sheath, high-power thulium fiber laser fragmentation settings may create temperatures of over 44 degrees that could potentially result in urothelial tissue injury. And take note that we were able to record these temperatures, these high temperatures, from the renal calyces themselves, as the temperature at the tip of the scope measured separately was actually noted to be up to 20 degrees lower than what's on the kidney itself. Now, it's just something to keep at the back of our minds when we're performing laser lithotripsy at high-power fragmentation settings, and probably even strengthens the use of the ureteral access sheath when we do RIRS. But then, all things being considered, the near future looks very, very bright for the future of ureteroscopy and laser lithotripsy, especially with thulium fiber laser. And lastly, it is important to touch on the latest technology in terms of diagnostics in urology. And just as technology has changed the way we treat urological diseases, it has also greatly affected the way we diagnose and monitor them. Now, it was just in the late 80s to early 90s when the clinical utility of PSA as a tool for screening and monitoring prostate cancer was demonstrated. And now, recently, with the development and more widespread availability of the multi-parametric MRI, we are again seeing a possible shift in the way we diagnose and monitor prostate cancer. And in terms of treatment planning, as we are becoming more dependent on imaging modalities such as CT scan, when we plan for minimally invasive surgery for stones and tumors, a lot of exciting new development is also going on in this regard. One example is going a step further with 3D reconstructed CT images that is now being commonly adopted to turn these 3D CT renderings into either 3D printed models or, as is typically employed at UCI, viewed using immersive virtual reality, which we have been demonstrated to improve surgical planning. But before I get to the next part, let me just mention the difficulty with making these 3D models for immersive virtual reality. It is quite cumbersome and takes quite a lot of time reconstructing the renal parenchyma, the vessels, the collecting systems, all of these manually, slice by slice from a non-contrast CT scan. And as opposed to high HU valued structures such as bones and stones, it would take manual effort to accurately delineate these anatomical structures from adjacent organs of similar density on a non-contrast scan. And now, an exciting development we have started to adapt for this purpose is the use of artificial intelligence to reconstruct the models automatically and with great accuracy. In partnership with the Center for Artificial Intelligence in Diagnostic Medicine at UCI, with a ton of existing kidney segmentations we have manually created previously, they started creating an algorithm that is able to generate these segmentations automatically. And comparing it with the ones done manually, we found very, very high concordance. Now, going to artificial intelligence, I'm not an expert in AI or programming at all, but I'll try to explain simply how it works. So, AI, specifically machine learning, works by feeding a system with certain amount of data, and then it classifies it according to certain features. And then as the machine gets feedback from the output from a lot of data inputs, an algorithm or a program is developed that makes it possible for the machine to learn by itself and be able to classify the newly inputted data by itself. Now, you probably are familiar with how this is currently being used, for example, by Facebook or Google Photos, to determine if someone in a picture is a certain person based on past tagged photos of that person. So it's very, very similar to that. And in urology, the input could be anything such as CT scan films, data from a patient's clinical history, or cystoscopic images, anything that could be converted to digital data. And then the output could be, for example, the machine learning to determine whether a lesion is cancerous or the likelihood that a patient would need hospital admission given his clinical history. And with this, the possibilities are now endless and the applications are really exciting. And what's more exciting is that it's actually already being used already in certain centers all around the world. For example, researchers from Stanford University have developed a deep learning algorithm for cystoscopy that could improve the detection of bladder cancer. You can see in the picture annotated boxes around the lesions, giving details about the tumors detected with cystoscopy. And gastroenterologists are also already using AI for colonoscopy clinically already. And it's very exciting how this is already benefiting patients. And at the rate these innovations are going, it is probably not too far in the future when performing a diagnostic flexible cystoscopy could be as simple as, say, inserting a Foley catheter, and then AI will be the one to do the diagnosing. And now, what's next? How about AI-controlled surgical robots that could, say, perform prostatectomies by themselves? Now, the possibilities are really, really endless and probably not too far off. I mean, we already have self-driving cars, which a decade ago, we wouldn't have imagined to happen in the near future back then. And as we have discussed all these new technology, we have really just scratched the surface of everything that's currently going on in urological innovations. And as exciting as these all are, and whatever comes next, we should always be reminded that the ultimate purpose of these advancements is to benefit our patients. And as one of my mentors in residency training would always remind us back then, at the end of the day, our goal is to always, always give our patients the best possible urological care that they deserve. Thank you so much for your attention, and good afternoon, everyone.
Our next speaker is the Deputy Executive Director of Nursing Services at the National Kidney and Transplant Institute. She is one of the most iconic women in Quezon City for 2021, given by Quezon City Tourism Department during the Women's Month celebration. In 2019, she is among the 100 most influential Filipino women in the world at the Innovator and Thought Leader category, awarded by Filipina Women's Network at its Global Summit in Westin Plaza, Paris, Vendôme Hotel, Paris, France. In 2017, she had numerous awards received such as Best in Public Image Award, Best in Vocational Service Award, Best in Economic and Community Development Award, Outstanding Project in Literacy and Basic Education Award, Outstanding Project in Maternal and Health Award, and Best in Rotary Club Fellowship Award. Dr. Herial earned her bachelor's degree in nursing at the St. Jude College and postgraduate Master of Hospital Administration at the University of the Philippines, and Doctorate of Philosophy in Nursing Education, major in Leadership and Management at the St. Paul University, Manila. She is also the founding president of Urologic Nurses Association of the Philippines, vice president of the Association of Nursing Service Administrators of the Philippines, vice president of the Department of Health Chief Nurses Association (NCR), and a co-founder and chief finance officer of Health Educators, Advocate and Leaders in the Philippines. She is a fellow of Association of Nursing Services Administrators of the Philippines, fellow of Philippine Society for Quality in Healthcare, fellow of Philippine College of Hospital Administrators, and an all-star president, Rotary Club of Chinatown Circle, class 2016 and 2017. Our next speaker, let us now welcome Dr. Nerissa V. Mendoza Herial.
Good day to all of you. To Dr. Paul Nimrod Firaza, the course director of this postgraduate course, and Dr. Rodrigo Hipol, the president of the PUA Mindanao chapter, and to all our online participants, it's an honor to join you here in this webinar. Again, I am Nerissa M. Jarial, the Deputy Executive Director for Nursing Services of the National Kidney and Transplant Institute and the founding president of Urologic Nurses Association of the Philippines, or URANAP. And I will be discussing about the essential healthcare services in the face of COVID-19 pandemic, the NKTI experience. Today, I will be discussing about the following topics: the hospital readiness checklist for COVID-19 from the World Health Organization, and I will share the NKTI experiences, workflow, and process changes during the pandemic. The current health crisis has challenged all sectors in the community, most especially the healthcare system in the country. Well, just to go back, the outbreak of a novel coronavirus disease in Wuhan, China, in December 2019 marked the beginning of unprecedented global spread of the disease, leading to a near collapse of the healthcare system in most affected countries. Well, I can say that the resilience of the health systems in response to COVID-19, including those in high-income countries, were all tested. Now, the question is, how did the healthcare system in our country cope with the COVID-19 pandemic? More than a year after the first COVID-19 case in the Philippines was recorded, globally, we have more than 160 million recorded cases, and in the Philippines, we have surpassed the 1 million mark for confirmed cases. Hospitals play a key role in providing health services and essential medical care within health systems. This role is particularly prominent during crisis. Many hospitals normally operate at near surge capacity, and so just a small rise in patient numbers during an emergency can pressure hospitals to work beyond their functional capabilities. The progressive spread of coronavirus disease during an outbreak can overwhelm hospitals' ability to respond, as there are simply too many patients needing medical care at the same time. Hospitals need to consider their readiness to cope with the influx of patients and increased need for medical services in times of crisis. They should prioritize and implement actions specified in their emergency preparedness plans for biological threats, specifically threats that may cause severe acute respiratory illness, in order to identify suspected cases, limit transmission within the facility, and provide medical care. This includes activating protocols and procedures. Specifically in safe physical spaces, emphasizing isolation measures, we need to assess our areas in the hospitals and if we have adequate isolation rooms. The education and training of our personnel is also very important. For example, in this situation, we need to teach them how to use the personal protective equipment or the PPEs and monitor them also if they're following the protocol. Regarding patient management, do we have enough knowledge in handling probable, suspected, and confirmed cases? And also sample collection and handling and disposal of hazardous biological waste. The benefits of an effective hospital-based response include continuity of essential services, well-coordinated implementation of a priority action, clear and accurate internal and external communication, swift adaptation to increased demands, effective use of scarce resources, and a safe environment for health workers. If we know what to do, especially in times of emergency or disaster, if you have a policy or protocol, if the people are trained and they know what to do, it will be easier for everybody to attend to the situation. For example, since we always have leptospirosis every year here in NKTI, we already made a leptospirosis manual to serve as guide for the new staff on what to do, what equipment or what supplies to prepare and others. We also made a COVID manual last year and all departments contributed to that, and we are now doing the second edition. The World Health Organization has also created a hospital readiness checklist for COVID-19. The checklist has been developed to support hospital preparedness and response for the management of COVID-19 cases. The elements described in the list may not apply to all hospitals and may need to be adapted to the specific characteristics of each hospital because some have different policies. So you can also look at the WHO checklist and use it as guide in making your own policies and protocols. These are the elements in the checklist to be assessed as we respond to the COVID-19 crisis. And it's divided into the following areas. First is leadership and coordination. Well, there should be a point person in every department to ensure that all plans and guidelines can be carried out to all levels of employees for operational support, logistics, and supply management. Another is in times of crisis, information and communication. Cascading of relevant information is very crucial to a successful crisis response. The next one is very important, human resources. Well, we all know that shortage of manpower has been a problem long before the pandemic started. We are very much in need of nurses and doctors. and other allied healthcare professionals. So it is very important that we have a contingency plan to address this concern. Aside from that, we should also assess the continuity of essential services and surge capacity. It can help to, alert the leaders and other authorities about where service delivery and utilization may require modification and investment, and would eventually help to maintain the provision of essential health services. Rapid identification diagnosis is also significant due to increasing outbreak of COVID-19. The early diagnosis of patients is crucial for prompt and effective prevention and control. Isolation and case management and infection prevention and control should also be in place to effectively respond to crisis. Since most of the hospitals in the Philippines are implementing almost the same protocols and guidelines, I shall tell you about the ones being implemented in our hospital, the National Kidney and Transplant Institute. Let me give you a little background about the NKTI. Well, NKTI is a tertiary specialty center for renal health and Asia's leading kidney and transplant center. We are also known for advanced patient care provided by its medical and nursing staff, particularly the treatment of renal diseases, dialysis, and organ transplantation. Well, in the Philippines, one of the top hospitals catering to patients, most especially renal cases, amidst this crisis is the National Kidney and Transplant Institute. In truth, nobody was ever prepared for this war. So how did the staff prepare themselves for the impact of COVID-19? Due to the rising COVID-19 cases, the management has set up precautionary measures for the immunocompromised patients of the Institute. With a prompt action from the different departments and in coordination with private and government agencies and even the non-governmental organization, including the UNICEF and the Red Cross, tents were set up outside the emergency room to accommodate probable cases and await results of their swab tests. With this, the medical staff can receive those patients at the tent, and they no longer have to bring them inside the emergency room, protecting the patients with kidney problems, mostly elderly patients who are having dialysis treatment, and post-transplantation, as they are one of those who are most susceptible to the disease. Patient cohorting was used to reduce the potential for cross-infection between patients and healthcare workers. So we have a tent for patients who are intubated, tent for hemodialysis patients, another tent for those awaiting lab results, and others. Here are some photos of the tents that we were able to set up at the start of the COVID-19 to accommodate our patients. These are also the tents set up in other hospitals such as the PGH and the RITM. Here are some of the policies and protocols implemented in our institution, basing on the guidelines set by the Department of Health, Centers for Disease Control, and of course, the World Health Organization. The nursing services, in coordination with the Infection Prevention and Control Committee, has conducted trainings for the NKTI staff for proper donning and doffing of PPE. And of course, the infection control measures to help protect the patients by performing procedures according to best practices and be continually equipped as NKTI opens door to care for COVID suspects with renal comorbidities. The practice of physical distancing and hand washing was overly emphasized, as these are the two of the most effective ways to prevent the spread of COVID-19. So, what are some practices of infection control being done in the COVID battlefield, and how are they being done properly? To ensure the safety of healthcare workers, most especially the hospitals in the Metro Manila and in NKTI have created the PPE safety officer role. So I know that all of us have patient safety officers. So the safety officer leads, protects, and guides through the processes of safely and correctly donning and doffing of PPEs. The PPE safety officer will be able to answer questions and give reassurance to staff that they are doing the right thing. It also gives confidence to colleagues that their safety now is the highest priority. So, in other words, the safety officer are responsible for monitoring compliance with PPE protocols, support the donning and doffing procedure going through a stepwise checklist, guiding, correcting, and assisting during donning and doffing, and also anticipating and planning for risk. Of course, prior to being assigned at the COVID tents, one must first protect oneself with the use of PPEs. We all know that PPE is a main source of protection for hospital staff, especially for those handling confirmed COVID positive patients. All personal protective equipment should be safely designed and constructed and should be maintained in a clean and reliable fashion. So it should fit comfortably, although we all know that wearing of the N95 and respirator mask for long hours can be very uncomfortable for our healthcare workers. So if the personal protective equipment does not fit properly, it can make the difference between being safely covered or dangerously exposed. Moving on, let's discuss about the process in the new triage consultation tent in NKTI. When a patient seeks consult at the ER, they will be initially screened at the ER triage tent. Majority of the hospitals have triage tents, including those in the provinces. So patient's chief complaint will be initially assessed by the triage nurse. Initial vital signs will also be taken. So once assessed, the triage nurse will endorse the patient to the concerned triage doctor on duty. The triage doctor now will do the assessment. For urgent medical needs, medical management will be administered at the triage area, and patient will be initially classified as probable or suspected case. For patients who come in due to severe respiratory distress, patient will be immediately transferred to the resuscitation area. So personal information and history will be obtained from a reliable companion while patient is being managed at the resuscitation area. So if the patient is stable, the triage nurse will facilitate the ordered diagnostic requests and laboratory workups. So all patients admitted in the ER will be swabbed to identify proper room or unit assignment. If patient requires admission and cleared as probable case, patient will be admitted to the ward. So we have designated wards for patients with pneumonia, and we also have wards for COVID positive patients. If the wards are full, patients will stay in their assigned tents in the ER or may be transferred to other COVID designated hospitals like Intala, RITM, PGH, or the Lung Center of the Philippines. In the ER tents, patients are already screened to determine the case prioritization and COVID stratification, whether they are pay or a charity case. We also do cohorting of patients in the hemodialysis units. As seen in the slides, we have identified specific areas for negative and confirmed cases. We put our COVID negative hemodialysis outpatients at our annex building and the COVID negative hemodialysis inpatient in our main building. So we have a separate area for COVID negative who will be needing hemodialysis. For COVID positive patients, we have a designated area also located, as I've said a while ago, in the main building where they are dialyzed. As you can see in the slides, we have 30 machines plus 15, so plus 6. So a total of 51 stations for COVID negative, and now a total of 16 stations for COVID positive patients. So during the start of the pandemic, we also have one big tent for hemodialysis patients. Well, aside from the existing hemodialysis facility of NKTI, recently we opened the modular hemodialysis facility for COVID-19 patients with a total of 20-bed capacity because of the increased number of patients needing dialysis. And some centers here in Manila have already closed and some are already full. So last May 2021, we did a short opening ceremony with DOH Secretary Francisco Duque, as you can see in the slides, Presidential Spokesperson Harry Roque, our IATF Chief Implementer and Vaccine Czar Secretary Carlito Galvez, DPWH Secretary Mark Villar, Quezon City Mayor Joy Belmonte, and also our partner, Debron Philippines. These are some photos of the modular hemodialysis facility that was built in the garden of NKTI. Also, a modular dormitory was built beside the modular hemodialysis facility for the healthcare workers that would be assigned there. So the dormitory has a 32-bed capacity. So let's go now to our critical units. In our hospital, we only have ICU and IMCU. Other hospitals have CICU, PICU, NICU. But let me share with you how we facilitate admission of suspected and confirmed cases at our intermediate care unit. General guidelines. The intermediate care unit is a designated unit for critically ill COVID positive patients. And the critically ill negative patients are at the intensive care unit. The patients there are endorsed from ER or from the ward. So just like the other areas, there is also a designated area for donning and doffing at the intermediate care unit. And there is also a designated safety officer every shift to check if the staff are following the set guidelines of the hospital. Visitation privileges is suspended for suspected and COVID positive patients, not only in the IMCU, but also in the designated COVID units. However, the nearest of kin or the authorized representative shall be required to be available for regular patient updates or any decision that has to be made for patient management. Next is all soiled PPEs shall be placed in double yellow bags to make sure that the staff who will be collecting it will not be infected. And once room is vacated, it shall undergo a terminal cleaning. After terminal cleaning, UV disinfection shall be facilitated. Those guidelines on waste collection and disinfection of rooms in the IMCU or ICU are also being followed in the other patient care areas of the institute. Well, moving forward, we also have our processes and guidelines in our COVID wards, or as we call it, our hot zone. We have 4 wards in the second floor of the main building. that is Ward 2A, 2B, 2C, and 2D. We designated all those wards for COVID positive patients. So I want you to imagine our four wards. The point of entry is our Unit 2A. Unit 2A is a designated donning and entry area of doctors, nurses, and other allied health staff who are attending to patients. There is also a designated safety officer at the donning area. Now, for the point of exit, Unit 2D is the designated doffing and exit area. There is also a designated safety officer at the doffing area to monitor compliance with PPE protocol. All patients from the hot zone shall be transported with an aerosol box. It shall be used and brought back to the unit and disinfected after use. So when a patient room is for UV disinfection, the aerosol box shall be placed there for decontamination, including the chart holder. When transporting a patient out from the COVID area or the hot zone, because they are considered dirty, the transport team shall don a new level 4 PPE with the word clean placed on the left upper part of the front of the coveralls. That is why they need to change and observe safety protocol. Then, the transport team may go back to the hot zone wearing the same PPE. Well, during this pandemic, we implemented the modified functional nursing delivery care system in the COVID areas. There are designated nurses who will only work at the bedside. And there are designated also charge nurses who will stay in the nurses station just to receive, carry out, and relay doctor's order to the bedside nurses. The main purpose of this setup is to minimize cross-contamination, and they are not allowed to cross over their designated areas of assignment. Let's go now to the operating room. Well, we all know that the worldwide spread of COVID-19 has led to a near total stop of non-urgent and elective surgeries across all specialties in most affected countries. Well, according to the study published in the British Journal of Surgery, each additional week of disruption to hospital services will be associated with a further 2.4 million cancellations. So during the start of the pandemic, an important question that is unanswered is when and how should elective procedures be scheduled again? And what kind of organizational changes are necessary to protect the patients and also the healthcare workers when clinics and practices reopen? Well, the transmission of the virulence of this new pathogen has raised concern for how best to protect the operating room staff while effectively providing care to the infected patient requiring urgent or emergency surgery. So initially, all elective surgeries here were put on hold, including kidney transplantation, as the Institute created guidelines and protocols as precautions for both the operating room team members and patients. We also benchmarked practices and at the same time aligned it with the international guidelines as we gradually accept patients giving priority to renal cases. Well, these are some of our policies and protocols that we have established, which I believe is also similar to the practices of other hospitals. To prevent inconsistencies in PPE donning guidelines, all other medical and paramedical staff going inside the ORRR complex shall comply with the donning guidelines based on the prescribed PPE worn per case or per procedure. So the COVID-19 wards and operating rooms require the most protection for personnel. This applies to all personnel in the areas where confirmed cases of COVID-19 are admitted. So They include healthcare workers who have to stay in these areas for at least 4 hours, and the anesthesiologist who intubate patients and stay for an entire operation. So level 4 PPE is recommended for patients with positive RT-PCR tests. If the patient for surgery is negative for RT-PCR test and result is within 5 days, the surgical team may opt to downgrade to the use of level 3 PPE. If test result was made more than 5 days from surgery, a repeat RT-PCR test is needed. Next is prioritization and scheduling of cases. Hospitals should establish a prioritization policy committee consisting, of course, of surgery, anesthesia, and nursing leadership to develop a prioritization strategy appropriate to the immediate patient's needs. In our institute, only emergency and urgent renal, urologic, and vascular cases and pre-scheduled kidney transplantation and those whose requirements are met were scheduled for surgery during the first months of the pandemic. In other words, we only do urgent and emergency cases. As we gradually resumed our services, when we schedule and prioritize surgery, some of the factors that we account for are list of previously canceled and postponed cases, and specialties prioritization like the cancer and organ transplants. So we started to accept elective cases during the latter part of the 2020 until this month. So unfortunately, due to the increasing number of cases, the management decided to suspend again elective cases and to prioritize only the emergency and urgent cases. Now, we are gradually accepting again elective cases. Other things to account for are identification of essential healthcare professionals. Do you have enough surgeons, anesthesiologists, nursing staff, and technicians per procedure? Because of this virus that affected the operations in the OR, you should also have strategies for phased opening of the operating rooms. In our hospital, surgical procedures will only proceed if all requirements are met based on the guidelines for the new normal hospital operations. So before the pandemic, we are doing kidney transplantation operations almost every day. And we gradually resume kidney transplantation surgeries now for 2 to 3 times a week. We also have room designation where all surgeries of suspected or confirmed 19 patients were assigned to be performed in a dedicated rooms so as to avoid patient and OR cross-contamination. So as you can see in this slide, our room designation in our hospital. COVID suspects or probable cases, patients with infectious cases, patient awaiting RT-PCR result should also have designated rooms. So we put up an OR satellite near the emergency room where minor and major operations of COVID positive patients are being performed. So this is outside the main OR building so as to prevent cross-contamination with our clean cases. Another recommendation is the OR complex traffic flow. There should be an established separate pathways to keep suspected or infected patients apart from non-COVID ones, protecting not only the patient but the healthcare workers as well. So in transit, surgical patients proceeding must not stop in any other place other than the COVID dedicated operating room, or they must be taken directly to a designated operating room that must be adequately marked with clearly visible door signs. Patient transit to and from the COVID operating areas must be as quick as possible. A predefined direct path must be kept as short as possible and away from other patients and people in general within the hospital in order to minimize the chances of infection. The operating rooms are equipped with high efficiency particulate air or the HEPA filters and undergo ultraviolet light disinfection either every after procedure or at the end of the day. So transport equipment like the stretchers, the wheelchairs, and other equipment are sanitized before and after use. So this is also the same with the other areas. Surgical instruments are routinely sterilized. There is also a regular disinfection of frequently touched areas such as the elevator buttons, railings, countertops, and doorknobs. There is also a scheduled wall-to-wall disinfection of hallways and corridors. Well, despite the current trends, RT-PCR test still remains as a requirement for all patients prior to admission and to employees or healthcare workers, especially those in the critical areas for healthcare monitoring. Initially, the staff directly assigned in the COVID areas were swabbed every 2 weeks. Thereafter, guidelines were revised, and instead of every 2 weeks swabbing of employees, it was done on a monthly basis. While the other employees not directly rendering care to COVID positive patients are swab symptom based. Well, in the latest Department of Health memorandum, as you can see in the slide, regarding the interim guidelines on prevention, detection, isolation, and treatment, and reintegration strategies for COVID-19 cases were updated as follows. For asymptomatic, the duration of isolation is at least 10 days from date of specimen collection. With mild symptoms, at least 10 days of isolation from the onset of illness, inclusive of 3 days being clinically recovered. And with moderate to severe case, at least 21 days of isolation, inclusive of 3 days being clinically recovered. Now, I would like to share with you some of what my staff have experienced on the battlefield against the coronavirus. So, when the pandemic hit the borders of the country last March, nurses were called to serve our countrymen, and each had to leave their families in order to care for the sick and affected. With a shortage of nurses in the Philippines implying a stage of havoc and disarray for the medical system, especially in the current situation of the country, hospitals still manage to have its spirited and strong-willed nurses fight a war they were not prepared for. Because we all know that they're with a patient 24 hours a day, 7 days a week. So in our institute, the NKTI, the nursing workforce serves as the backbone on the front lines of fighting against the invisible adversary, the COVID-19. So I do believe that we empower each other by being connected to one another, communicating our needs and differences, and showing camaraderie every step of the way. Yes, I can tell you that there are staff issues also because they are afraid, they are anxious, but we make sure that the leaders are there to support them and help them along the way. At the start of the pandemic, nursing staff have been working for long, grueling hours, finding themselves risking their lives every day. In NKTI, there are certain practices that are enhanced and modified in order to care for those affected by the virus. Well, the nursing services, in coordination with the Infection Prevention and Control Committee, has conducted trainings for the nursing staff, or as I've said a while ago, for the proper donning and doffing of PPEs, and infection control measures to help protect patients by performing procedures according to best practices, and be continually equipped as NKTI opens door to care for COVID suspects with renal comorbidities. The practice of physical distancing and hand washing was overly emphasized to the nursing staff, as these are the two of the most effective ways to prevent the spread of the virus. So I know that most of the hospitals are doing the same. Along with the increasing number of COVID-19 cases worldwide, came also the global shortage of PPEs and other necessary supplies. Safety concerns are high given the dearth of protective equipment. Nevertheless, with the endless support from both the private and public sectors and others who are willingly share in the spirit of what we call bayanihan, donations and help for our frontliners are coming from all parts of the region. So it is good to know that it is easier to acquire PPEs now, unlike during the start of the pandemic, where most of our PPEs came from donations from different local and private organizations and even individuals. Well, in our efforts to combat the current health crisis, the Philippine government has procured vaccines from China, UK, USA, and Russia. The rollout of vaccines, given the limited global supply, shall be based on a prioritization framework to ensure that those who have the highest risk exposure will be protected from the disease. So just to show to you, this is the NKTI COVID-19 vaccination team 2021. So the COVID-19 vaccine rollout last March 1, 2021 marked a historic event as the government began its biggest vaccination driven in scale following the receipt of 600,000 donated CoronaVac doses. So on the first day of the rollout, at least 756 frontline healthcare workers from 6 hospitals in Metro Manila received the Sinovac CoronaVac, with PGH Chief Dr. Gerardo Legaspi being first to be inoculated in the country. Well, I was also able to take part in this historic milestone in our country as a nurse wife who vaccinated her doctor husband. So this was also featured in TV Patrol, Rappler, Manila Times, and nurseupdates.com. Along with the nursing leaders, we continue to conduct leadership meetings to constantly plan and address concerns arising both in the administrative and even in the clinical areas. So schedules were really strategized in a way that the staff will be able to prepare, have ample time to rest, and regain strength before coming back to the battlefield stronger than ever. So just to let you know, it was in mid-March when those affected by the outbreak started swarming in hospitals. So NKTI being the premier hospital catering to renal patients then accepted cases with renal complications. So the nursing staff were at first really overwhelmed, given that most did not anticipate the burgeoning of cases in the Philippines. But eventually, you know, over time, they were able to find ways to cope with the hard reality that every person is really battling. Well, because of this, when I heard about their being discriminated or being driven away by their landlords in their communities and barangays, I personally wrote a message of hope addressed not only to the healthcare workers, but to the community as a whole. And I'm glad that it was published by Nurse Updates, but it was also shared by Rappler, Inquirer, Manila Times, Daily Tribune, Metro News Central, Go Cavite, Go Batangas FB page, and other media, social media platforms. So aside from that, I being their mother in the nursing services, I wrote a letter to all my more than 800 staff, giving them hope and encouragement saying, kamusta ka, mag-ingat ka, sampu ng iyong pamilya. Well, it is my way of reaching out to them, as I cannot personally talk to them every day. I wanted them, to feel that they are valued, and, and the whole institute remembers and appreciated their sacrifices. NKTI was not immune to the virus, and several of my staff tested positive. I think more than 200 plus of my staff got positive. With this, I felt the need to write them another letter stating that I am with them and that they are in my prayers. Well, it is the nurses' appeal to the society whom they are serving that they be treated with respect and sympathy and not be treated as outcast by being disease carriers. The nursing personnel, sincerely appreciate the empathetic citizens who have volunteered in donating whatever they have to help, from the meals given down to the PPEs in any form, and even prayers offered every day. Well, these things help them realize that they're not alone in this battle. These things give them courage to continue in the fight of serving the Filipinos in this COVID war until we win it. So, my dear doctors and my colleagues in the nursing profession, I just want to inform you that there is pain for leaders too. It's no easy job to be a leader. What the staff is experiencing can also be felt by the leader. Every time, I just want to share this with you, every time I talk to my staff and hear them cry, I feel their pain. Especially if they will say, Ma'am, paano na po ang pamilya ko ngayon nag-COVID positive ako? Paano na po ang mga anak ko? Masaswab din po ba sila? Saan po ako titira? Maliit lang po ang bahay namin, iisa lang po ang kwarto. Natatakot po ako. Ano po ang gagawin ko? Well, hearing those words breaks my heart because I know that I cannot cure them of their infection. But what I can give them is my support, prayers, and concern. It's good that, the government and other private sectors are helping us provide accommodation and transportation for our healthcare workers. If the COVID positive staff cannot quarantine at home, we have a partner hotel where they can stay. Those who cannot go home because of transportation problem, we also have an accommodation facility for them. And we truly thank those who are helping our healthcare workers. Above all else, the biggest and perhaps the hardest sacrifice a healthcare worker can possibly give would have to be the time spent away from their families and loved ones in this time of crisis. These sacrifices are the realities lived by the people nowadays. Through this, they are able to save lives, even if it means putting their own at risk. I know that no monetary or other incentives could compensate to the work and sacrifices of our healthcare workers, but I believe that we are tirelessly working because the nurses, the doctors, like the rest of the frontliners, are aware of their chosen profession and the risk that goes with it. And we have pledged to do our duties no matter what. So it is our passion and our calling to serve the Filipino people during these trying times. Every day, we are faced with the threat of COVID-19. That is why I would like to give credit to all our healthcare workers, our doctors, our nurses, the medtechs, and other frontliners in the hospital on how resilient they have become, despite the impact of this crisis, both physically and psychologically. We all hope for an end and cure to this disease, and the world continues to adapt to the changes that needs to be done to achieve this. Before I end my lecture, I would like to say to all of you, we are not blessed because everything went right. We are blessed because we got the fight. Thank you and keep safe.
Our next speaker earned his degree in medicine and law at the University of Santo Tomas. He then trained in forensics at the PNP Crime Laboratory Service at Camp Crame. He also earned a degree in criminology at the Philippine College of Criminology. He's an assistant professor and lecturer at numerous colleges of medicine and law in Metro Manila. He is also a medico-legal consultant of numerous government and private hospitals in Metro Manila. He is the current chairman of St. Luke's Medical Center, College of Medicine, Department of Legal Medicine. He has delivered over 1,000 lectures as speaker, lecturer, panelist before the health and legal community since 1993 on topics covering medical malpractice, health laws, ethics, and forensic medicine. He holds clinic at the St. Luke's Medical Center and practices law through his law firm Castro Rebosa Rebosa and Associates. But wait, there's more. You can also catch him as lead vocalist for Retromaniacs, performing regularly at RJ Bistro, Dusit Thani Hotel, Makati during Saturdays 9 p.m. to 12:30 a.m. Let us now welcome our next speaker, Attorney Antonio Alejandro D. Rebosa, MD.
Good day, everyone. Thank you for inviting me over to give you this lecture on the medical legal issues in urology practice. Well, it's a nightmare for any doctor to have a threat, no? When patients threaten you with a lawsuit or actually file a case against you. In the United States, urologists rank 12 out of 28 specialties when it comes to malpractice cases. And it is estimated that urologists would at least have 2 cases within the span of their career. We do not have the exact statistics here in the Philippines, but again, of course, is practice of surgery. And in the last few years, OB had already overtaken surgery as the #1 specialty with the most number of malpractice cases. So #1 is now OB, followed by surgery. And of course, when we talk about surgery, it encompasses all the specialties, or subspecialties in surgery, uro among them. And over the years, we've had clients or doctors who have been actually sued, for not only for the practice of urology, but of course at the PRC, when they file cases against you, it is for unprofessional and unethical conduct. So the usual medical legal issues in urology practice is quite the same for all specialties. So as they say, ignorance of the law is not an excuse from compliance therewith, but I'm sure you all know the law, but it's very difficult, even when you are very meticulous in your practice, you'll never know when lightning is going to strike you. Now, this is very true. Establishing one's medical practice after all that schooling and training takes a lot of sacrifice and guts. Right? You went through med school for about 9 years, internship of a year, medical board exams, then you go through residency training and fellowship, subspecialties. Okay? And one's reputation is built through many, many years of hard work and perseverance. But it only takes one perceived catastrophic mistake to destroy and put to waste all of those laurels and achievements. So protecting one's practice is never easy, as there are many unpredictable perils like difficult or impossible patients or parents. And you also have state regulations like Republic Act 7610, the anti-child abuse law. Also, you have Presidential Decree 169, which is mandatory reporting of all cases involving less serious and serious physical injuries. As urologists, you will also have patients with who would fall under these particular laws. If your patient is below 18 years of age, practically legally he is a child. And you also have trauma patients. And If he's a trauma patient and you are the main attending physician, no, this is if the injuries would fall under the classification of less serious and serious physical injuries, then you will have to report that. And this particular law is specific for doctors. Okay? It is your head, no? It is your license that is at stake. But what we usually do when we have trauma patients is that we usually delegate it to security people. No? So if security fails to report it, the police will not go after security. They will go after you because the law says that it is the doctor that should report this particular incidents. So you have to monitor, no, security or whoever is in charge, whoever is the hospital assigns, no, to report these cases, because it is not them, no, it's not their head that is at stake. It is the head of the doctor responsible for reporting. So unwanted and unforeseen complications could usually end up in a media backlash or litigation, especially for the last 20 years. No, times have really changed. It used to be that patients would threaten you with a lawsuit. No, right away they would threaten you with a lawsuit. But this, and then later on, they would threaten you with that they will go to the media, okay, and radio, TV, newspapers. But now, the last 5-10 years, they threaten you that they will go to the social media and destroy you. So usually these problems starts with an unfortunate, unwanted, unavoidable clinical mishap or event. Of course, no doctor would ever want harm or death to happen to a patient. But accidents do happen, unforeseen, unwanted complications and risk. No? And when that happens, the patient or their next of kin, no, they allege negligence on your part, incompetence, ignorance, arrogance, impropriety, sexual misconduct, okay, unethical and unprofessional behavior, blah, blah, blah. So they're going to throw everything at you, including the sink. Now, let's review again the 3 kinds of liabilities. As doctors, of course, no, we have 3 kinds of liabilities: criminal, civil, and administrative. So for criminal cases, the usual complaint against you is that you are reckless, no, you are negligent, and your recklessness is inexcusable, not justifiable. And again, we did not intend to do that. But since negligence is also punishable, no, and if the patient dies supposedly because of the negligence of the doctor, Article 365 of the Revised Penal Code will come into force, and that would be reckless imprudence resulting in homicide, which carries with an imprisonment of a maximum term of 4 years and 2 months. Now, general rule. Usually, the only one that is criminally and administratively liable is the doer of the act. Kung sino ang tatanga-tanga, sino ang nakagawa ng krimen, siya lang ang makukulong, siya lang ang matatanggalan ng lisensya. But somebody else may be made to pay, no, in the form of damages, and that would now be the so-called civil liability. So you have damages, no, moral damages for besmirched reputation, social humiliation, sleepless nights, serious anxiety, mental anguish, fright, no, and the like. Then you have actual and compensatory damages, no, damages that can be proven with certainty, one with a receipt, okay. Then exemplary damages or corrective damages as an example to the public, no, as a deterrent para hindi pa marisan ng publiko ang ginawang kabalbalan ng doktor. The court will award more damages. Okay. Now, usually, when there's a problem, no, it usually starts with a complaint from the patient addressed to the hospital. But in many cases also, no complaint is filed with the hospital. What you will usually receive before a case is filed against you would be a demand letter, no, coming from the lawyer, or in some instances, just a demand letter coming from the family. It used to be that the record, at least for our law office, when it comes to demands, no, the highest demand that we've had about 10 years ago was 100 million pesos for a patient who supposedly died because of the negligence of the doctor. But about 5 or 6 years ago, we had this case of I think a 10-year-old boy who underwent circumcision, no, in a medical center performed by a urologist with an anest social. No? Circumcision lang. No? Pero ano siya. And they did the circumcision in just about 20-30 minutes. Patient was up and about, and patient was sent home right away. But lo and behold, no? After about 2 months, or just a matter maybe about 3 or 4 months, the urologist received a demand letter from the lawyers of the patient. No? Apparently, the boy who underwent circumcision had inflammation, the usual kamatis, infection, and ended up with skin grafting in another hospital. And the lawyers were claiming that because of what happened, this boy probably would now grow up to be impotent, will not be able to enjoy sex, will not be able to procreate. Pero my God naman, ano lang naman yun eh, skin grafting, hindi naman nadama yung kanyang nerves or, you know. And they were demanding the astronomical, outrageous sum of 250 million pesos, which the urologist should pay within 10 days from receipt. My God, ano kala nila sa atin, no? Mga doktor, nagtatain ng pera. No? Kahit nga siguro yung stool exam, walang 250 million na bacteria eh. No, but that's true, from about 5 or 6 years ago. No? Right now, we're handling 2 cases also involving circumcision. Okay, unfortunately, the boy who 10 or 11-year-old boy, no, had circumcision at about 8 in the morning, went home at about 9. Nothing untoward happened, except that within the same day, at about 8 o'clock in the evening, the boy was rushed to the emergency room where he eventually was pronounced dead. And the doctor who performed the autopsy stated that the cause of death was propofol. My goodness, no? And propofol naman eh, di ba, ano lang yun, 15-20 minutes, wala na sa body mo, no? So something might have happened because the boy was up and about when he was sent home an hour after the procedure, no? And in this particular incident, the anesthesiologist, no, was, well, together with the surgeon who performed the circumcision, was criminally charged, no? And well, ultimately they were acquitted, but at what cost was it? They had to go to court, they had to pay for lawyers, warrant of arrest was issued. No, and in fact, even the anesthesiologist, he spent 1 night in jail, no, before we could post bail for him. In another case, I think also an 11-year-old boy, no, underwent circumcision in the operating room, no, and unfortunately, while at the after the circumcision, no, patient went into cardiac arrest and died about 2 or 3 days later. The case is still ongoing. No? It was the surgeon who was sued. No, so you see, circumcision is very, very minor. No, it's really nothing. But you'll never know when accidents would really happen. No, and I guess please do not use the term minor, kasi ang tingin nila pag minor, there's no morbidity, there's no mortality. Okay? So refrain from using the term minor or sandali lang yan, no? I mean, you still have to explain that there are innate risk, no? Or things could happen beyond your control. Although it's general knowledge, no? Circumcision lang. Again, huwag nating lalang-langin. Okay? Sa mga pendectomies nga, do not use the word simple, minor. There's nothing really simple, especially when you go to make use of anesthesia. Now, for administrative cases, this is for violation not of the law, but for violation of the code of ethics, no, and or violation of guidelines and policies of your specialty societies or some other administrative bodies. No? And when we talk of administrative bodies, this is when a complaint is filed against you before the Professional Regulations Commission, of which it is the Board of Medicine that will hear the case. No? And before the PRC, what is at stake is your license to practice medicine. Or the case is filed before the Philippine Medical Association, and it's the Commission on Ethics, no, that will hear out the case. But of course, the only powers that the PMA has is your membership with the PMA. And as of now, membership even with the PMA is not mandatory. But there are certain privileges that only PMA members in good standing can avail of, the most important of which is accreditation with PhilHealth. Or they might file the case, no, within your own society, Philippine Uro Association. And what do they want? No, they want you, perhaps if you're a fellow, no, they want you expelled from the society, no, or they could file it before other again, the specialty societies like POGS, PSPS, no, PCS, and the like. And again, the issue here is not really violation of the law, but for unethical, unprofessional conduct, immorality, or evident bad faith in dealing with the patients. So at the PRC, no, there. When we talk about ethics, it only means two things. One, standard of care, and medical etiquette. When we say standard of care, as doctors, and even for you guys, no, you're specialists. Okay? You're supposed to keep abreast with medical developments. You're not supposed to be stagnant. No, if you deviate from the standard of care, okay, that your specialty requires, then and if something happens to the patient, then you could be held liable. But it's not only medical practice, no, that entails or part of our ethics. As I've said, it's also medical etiquette. As doctors, we belong to a very noble profession. That's why we're supposed to be noble. You're supposed to be upright and sober at all times. So, lasenggo ka, adik ka, babaero ka, you're not a good example. No? So, you can be charged before the PRC. We've had cases, no, actually more than 30 to 40% of the cases that we have has nothing to do, no, with the practice of medicine. It's more for impropriety, sexual misconduct, no, that's why sexual harassment, no, you have to be careful with what you say, no, towards your fellow doctors and to the patients, because it might be misconstrued as being sexual in nature, no. We have had cases in which doctors were sued before the PRC for bouncing checks. So, lahat pwede. And the PRC does not dismiss cases. No? If somebody files a case against you for possession of an ugly face, the PRC is not going to dismiss that. You will actually still receive summons, no, for you to answer and defend yourself that even if you have an ugly face, no, you're still entitled to practice medicine, and I'm not kidding. You are given 15 days within which to submit your counter affidavit. So they don't dismiss cases. Okay? But of course, if in criminal cases, no, you lose the case, you get convicted, you go to prison, you're ordered to pay a fine. No, in civil cases, you're ordered to pay damages. You have to indemnify in the form of money. But administrative cases before the PRC, and if you're found guilty of unprofessional and unethical conduct, the PRC does not have the power to send you to jail. It does not have the power to order you to pay damages to the patient, because the only powers that it has is to reprimand. No, reprimand is a very stern warning, still a sanction, okay? And or suspension and or revocation of your license to practice. If your license is revoked, you can still renew your license, no, every 3 years, as long as you were able to file a timely motion for reconsideration and appeal all the way up to the Supreme Court. No? In PRC cases, there is no whole departure order, there is no warrant of arrest, and you don't even have to be present during the proceedings, except, no, when it's already your turn to testify. Same thing with civil cases. No, your presence is not required as long as you have a special power of attorney. Unlike in criminal cases, it depends upon the judge whether to grant your waiver of non-appearance. So hassle talaga, no, if it's a criminal case, because you are required to be present always. Okay. When I say expulsion here, no, the penalty of expulsion would be from the PMA and all the other specialty societies. Or if they file a case against you before the hospital, what do they want? No, they want the hospital to either suspend you and or to terminate your services. Now, common issues, no? In about 90% of cases being filed against doctors, the complainants are always saying, or they're alleging that the doctor did not conform to the standard of care that is required of his profession or his specialty. No? And usually the question that is asked there, or the standard is, did the doctor exercise the diligence of a good father of a family in the treatment of his patients? So what is diligence of a good father of a family? Okay? That is for something for the court to decide. Oh, what is that standard? And who is going to say whether you had the diligence of a good father of a family? No? If the issue is uro practice, the patient is claiming that the urologist did not conform, or the uro deviated from the standard of care, then he will need to present an expert witness. An expert witness, no, is any registered physician. Okay? So even a general practitioner can be presented as an expert, okay, and in fact also testify. Now, the medico-legal officers of the PNP and the NBI, only very few of them are specialists in a field. No, most of them were general practitioners, and they're not even clinically or seeing patients for purposes of treatment. No, and yet they are being utilized or being presented as experts. No, when it comes to their autopsy findings, no? Because usually when the relatives suspect that there was medical negligence, autopsy is done and performed by them, and they testify. They would be testifying with their findings, and even if they're not specialists, they are not pathologists. No, they are being presented as such, because any registered physician can be presented as an expert witness. So usually when there are doctors that are willing to be to testify against you, then it becomes a battle of credentials, credibility, and professional standing. So if you're a urologist and there are urologists willing to testify for you, or if the society would come out with a resolution after reviewing all the records, and there would be a favorable resolution on your part, then you should be in good stead. Because who among the fellows, or the members of the society would go against the very resolution made by the society? So again, this would be a battle of expert witnesses, and when there are expert witnesses, then again, as I've said, it will be a battle of credentials and professional standing. Only very few doctors are perhaps in the Philippines willing to openly testify. Maraming meron sa atin, but only very few are willing to really go to court and testify and or sign documents or affidavits, and the like. But lately, we have had cases in which, because the patient has a difficulty in securing these services or the testimony of Filipino doctors, they've been getting doctors from abroad. We've had the case from still ongoing. There were 2 Phil-American doctors who came to the Philippines and testified against our clients, and they were former Filipinos who took up medicine here and have been practicing in the States for about 30-40 years. And their trip to the Philippines, of course, was sponsored and paid for by the patient. We have had also some doctors from Singapore and Australia coming over here. So if the patient can afford such witnesses from abroad, they can be presented also as expert witnesses. Yun, may problema na tayo doon. Pag yung talagang there are doctors na palaban, and really willing to tell the court that, yes, Your Honor, that doctor is negligent. Mahirap na. Well, other problems that we might encounter really would be the under the electronic evidence law and cyber crimes. No, as I've said, things have changed over the last 20 years with the advent of internet technology. No, ibang-iba na yung practice natin: social media, text messages, emails, and of course, doctor shaming. No, and almost every day I get text messages from my former students, doctors that I don't know from the Visayas and Mindanao, no, dito sa Luzon, lahat 'yan, no. Hindi tayo ligtas kasi global na tayo, the reach of social media, no. One single mistake that they think you have committed, they will post it, no, in just a matter of a few hours, meron ng 1,000 views with about 30 comments, no, and after one day 300 comments na, and wala man lang pabor sa'yo sa doctor. And if this happens, no, do not engage them. Just take screenshots of the postings, no, and let's see if we do have a case. But usually when I get calls from the doctors, no, kasi mga Filipino doctors talagang very impulsive yan. Doc, there is this Facebook post, no, that has been going since about 3 days ago. No, they posted my picture, blah blah blah. And they've been over 3,000 views with about 300 comments. Ang sasama talaga ng comments. Gusto kong magdemanda. And I always tell the doctor, Doc, get some screenshots, no, everything, no, lahat. And then call me back after 2 weeks or after 1 month. Then, Doc, gusto ko na magdemanda ngayon. And I would tell them, no, 2 weeks or 1 month. Why? Because the normal lifespan of all these negative posts is no more than 1 week. Ganun naman mga Pinoy. No? Gusto lang manira. After that, iba na naman yung flavor of the week. No? So, after 1 week, if I get your case now, and bayad ka na sa abogado, and then after 2 weeks, no, malamig na ulo mo kasi wala na. Doc, pwede bang, attorney, pwede bang pakibalik na lang yung binayad ko sa'yo? Of course, but once you've already paid the lawyer, that lawyer is not going to reimburse you anymore. No? So, mga doktor talagang impulsive. So, I just tell them, wait for 2 weeks. And none of those who called me, no, had ever tried to call back again after 2 weeks. So, siguro wala na. No, lumamig na rin ang ulo because as I've said, no, the normal lifespan of all these negative comments being posted is just 1 week. Pabayaan na lang siguro, no? Unless talagang below the belt. Okay? But you can file a case against the one who posted those negative comments against you. And if it's really libelous, then it's cyber libel. Please take note that you cannot file a case of cyberbullying. Cyberbullying, the law on cyberbullying is only for high school students. Those who are 18 and below, no, matatanda na tayo. So hindi cyberbullying ang kaso, hindi cyber libel. Okay? So again, text messages, emails, they're also admissible in evidence, and we have to be very, very careful about that. No, especially with the data privacy law of 2012. Be careful with what you text, what you email in our Viber groups. Ako, ilan na yung napatrouble dyan sa mga Viber groups na yan. No. Inadvertently, I'm sure this has also happened to you before. Yes, for me, no, you send emails and text messages to unintended recipients. Okay? Yung Viber group, it's really not that private anymore, no? Public na yan kung marami yung members. I think if there are more than 50, it's no longer considered a private group. So if you inadvertently posted a medical certificate of a patient, no, without, of course, the authorization of such a patient, then baka may kamag-anak siya doon, no, especially pag mga contagious diseases yan, you could get into trouble, okay, under the data privacy law. No, I have so many patients now, or sorry, I have so many cases, no, in which napaka-trivial. No? So you have to be careful. Yung mga, like in one case, there was this elderly patient brought to the emergency room by the spouse, by the wife. No? So the resident interviewed both the husband and the wife. After that, the resident did some diagnostic tests. No? And since the patient was in the stretcher, no, I think she was probably sleeping. the resident talked to the wife and disclosed the findings to the wife. Okay? And about 2 weeks later, no, HR received a complaint from the patient. And I was complaining about the resident for talking to the wife. Eh, yung wife na nagdala sa kanya. Who would ever have thought, no, na ayaw pala ng pasyente na makausap ang wife. So again, very trivial, pero these are actual cases, the complaints. In another case, after a week, no, on the same hospital, a female patient was about to undergo surgery. And again, she wanted that the procedure be explained to her. And she was quite a difficult patient, and she was in the ward. No, say ward probably apatan yata yung room. No? And the surgery was to be done in the afternoon, so the resident again went to see her, and for the third time explained to her the procedure. Unfortunately, when the doctor went to see her, the patient was in the comfort room, and so the doctor and the patient talked, no, about the procedure with the patient inside the comfort room and the doctor outside. And surgery was done, and about 2 weeks later, a complaint was filed against the doctor resident because supposedly because of their conversation, other patients overheard what they were discussing. But still, it wasn't really that shameful, or ang pinag-usapan lang nila is the procedure for appendectomy. But again, a complaint is a complaint. So you have to be careful, no? Ngayon kahit ano na lang, no, nagdidemanda or nagko-complain ang mga pasyente. Now, golden tips for urologists, which from the American College of Legal Medicine, of which I am a fellow and a diplomate. No? For urologists, it states there that always be familiar with recent developments and guidelines of your specialty society. If your specialty society will defend you, then have no fear. But the specialty society will only defend you if you had adhered to the policies and the guidelines. Usually what we do, well, for fellows and diplomates, no, with complaints coming from the patients, we ask the specialty society to have a peer review. No, we submit all the records and the complaint for their respective committee on ethics to review. And if the review is favorable, no, they issue a resolution, and that resolution is one of our documentary evidence that we will be presenting in court. Please take note that again, it's a battle of expert witnesses. The judge is a lawyer who may not know anything about medicine. So he has to be enlightened by a doctor. So as I've said, it's a battle of witnesses, and who would be more credible over the other? And that's where credentials and professional standing would come in. Always find time to substantially discuss the patient's case, including alternatives, the procedures that you don't or you cannot perform, no? Morbidity and mortality. Of course, medyo lahat naman, no, may morbidity. So that's something that should be discussed, and also the cost among others, no? So this is what we call informed consent, and everything should be documented. That's why our consent forms has evolved through the years, no? From a simple consent form ngayon, 2 to 3 pages, tapos nakasulat pa doon yung mga that you have personally discussed the following, no, or the possible risks and complications, if at all these complications would really set in. Now, what would it be the mode of treatments? Their number 3 tip is that screen all the male patients for prostate cancer. No? So, and then PSA. So, basta male patients above, how old was it for you? I think it's 40, no? Dapat meron ng digital rectal examination, and you have to ask for this prostate test. Okay? And always ask the patient on their sexual function prior to you doing anything, and document that, because they could claim that even if you were able, no, to cure and treat their problem, but it resulted into some sexual dysfunction, then they can sue you, no? especially sa mga lalaki, mas importante sa kanila yung pagkalalaki kaysa dun sa matreat yung kanilang problema. No? And how are we going to prove that it would be very difficult to go to court and talk about something that we have not documented before doing any surgical intervention? Number 5, of course, refrain from criticizing another urologist or a referring physician. As they say, behind the success or failure of a man is a woman. Behind every medical negligence case is another physician. No? Tactless, irresponsible statements made by other physicians. That is the number one cause why there's a spike in medical malpractice lawsuits, no? Being filed against doctors. Marami sa atin mga miron. Normal lang yung magmiron. Pero yung pagmimiron natin na yan, it can result into lawsuits. No? And wala namang may gusto sa atin mag-testify. So golden rule, don't do unto others what you don't want others to do unto you. Number 6, personally review all the films and other test results before surgical intervention. No? Of course, we're not saying that you are better than the radiologist or the ultrasonologist. But sometimes, meron din problema eh. I'm sure you know what I'm talking about. So do not just depend on the white paper, yung resulta. No? Just like me, I always depend lang kung ano yung written results. Hindi naman ako marunong magpasa ng x-ray. When I prepare my medico-legal report, no, I'm just going to write there the pertinent findings of the radiologist. But for you guys, you have training, no, in radiology. So before you do something, personally review all the films, especially nga sa mga orthopedic surgeons, no. Some radiologists would say there's no fracture, but for the ortho there is a fracture, and no, before you know it, nagka-problema na. Okay? So personally review all the films. Do not just depend on the written findings. And also, always ask for the medications of the patient, because the medications perhaps that you might be giving to the patient, no, would be contraindicated or would have some adverse effects because of the medications being taken by the patient, no, for some other illnesses. Okay. And number 8, warn your vasectomy patient that sterility cannot be assured until he has a negative semen analysis. And again, document. Because without documentation, hirap yun. So parang yung mga nagpa-ligate ng mga babae, nabuntis pa din. So it's the OB's responsibility, no, to explain to the patient. Kayo naman, urologist, no, you have to explain and document. Dapat pirmado ng pasyente that it was explained to him, no, that there's a certain time period before there would be a zero semen or zero sperm. Okay? So you need to practice defensive medicine. Defensive medicine means that not really asking for a lot of useless, no, or unnecessary diagnostic tests, but more for documentation. You'll never know, as I've said, when you would be needing these documents. Before performing the surgery, you explain to the patient, maybe it would be best that you do some sketching and diagrams, no? And then later on, after you have explained to the patient, make the patient sign those sketches that you have made, so that if the patient later on would say that you never spent time explaining the procedure, this has happened already a few times to some of our clients, no? They were saying that the doctor they only talked to them for about 5 to 10 minutes. But no, the doctor presented several documents, mga drawings, duly signed by the patient. So it would not have taken 5 minutes. So documentation is very, very important. Now, Melvin Schiffman is a pediatrician who's both a doctor and a lawyer, and I completely believe what he said, no? That there's no complete solution to medical malpractice, since any patient may sue the doctor for actual or imagined injuries. No? There's almost always a lawyer who's willing to take on any malpractice suit and find an expert who will testify for the patient. Unfortunately now, babawiin ko yung sinabi ko kanina, meron na din tayo mga doctors, no, willing to testify. against doctors. And they are also specialists. So it is the prepared doctor who has maintained his practice with forethought that will be protected against such intrusions. But of course, I'm not in favor of really practicing defensive medicine, meaning you'd be requesting for so many unnecessary tests just to protect yourself. That should not be true in the Philippine setting. Na headache lang, magre-request ka na for CT scan, X-rays, EEGs, no, and the like. But as I've said, you'll never know when lightning is going to strike you. So it is the prepared doctor, no, with foreseeability that can perhaps, no, avoid having these problems. And with this, I'd like to end my lecture. And I hope everybody of you, all of you, are safe. And you never have to call me. Maybe hopefully when this pandemic is over, when you come to Manila, I can again resume my other profession, which I love more than that of being a doctor and a lawyer. So thank you so much for listening. And anytime you run into problems, you can call me, or you can call up our law office or my younger brother, Abed, and we'll try to help you out. Thank you, and good afternoon, everyone.
Greetings, ladies and gentlemen. In behalf of the Philippine Urological Association Mindanao Chapter, Vice President Dr. Manuel Gerard Sevilla, I'd like to formally close the second online 16th PUA Mindanao Chapter Postgraduate course entitled Urology Practice Hack 2.0. This past several hours has been a very informative educational learning experience for all of us. I'd like to thank first and foremost our distinguished speakers for sharing their valuable time, knowledge, and expertise. Secondly, I would like to thank the organizing committee headed by Dr. Nimrod Raza, whose tireless effort made this event a reality. And thank you to all of the PUA Mindanao chapter of officers and members for their contribution. Thirdly, to our valued partner and sponsor, ECE Pharmaceutical Corporation, for their unending support, and without whom this event would not be possible. Lastly, thank you to all the participants whose interest motivates and encourages us to pursue and improve on this PUA Mindanao Chapter yearly event. So again, thank you everyone and have a good day. Good afternoon.